Myself, Saurabh Sandelia. I'm in charge of My Rehab Academy, in charge for academics as well as the strategy. First of all, my request to every participant is to switch on your video, and the video must be switched on for minimum 70% of the total time of the webinar, and your audio must be switched on for at least 90% of the total time. Our technology staff is checking it very properly. So failing for this may lead to either delay or maybe you may not get certificate very soon. So it's very important. I think you have got on the WhatsApp all the terms and conditions. So kindly keep your video switched on throughout the webinar. As I said, minimum 70% or whatever is there in the terms and conditions. Other thing is, Dr. Pallavi, will be the instructor for today. Before that, I will let you know something about the My Rehab Academy. My Rehab Academy, as you all know, that it is the platform which connects the best of instructors across the globe to the physiotherapy students, professionals, as well as the academician for upgrading their knowledge, skills for their better use in the clinicals as well as academics. And you guys have made My Rehab Academy to reach a very good height. My Rehab Academy wishes you very happy Dasara, the festival for self-realization, self-transformation, and self-awakening. Here at My Rehab Academy, as you all know, our presence on social media is quite viral, and we have been awarded for the best rehab education agency in the India for year 2019 by one of the leading agency called Brand Volts. And our presence you can feel across the social media, especially over Facebook, as well as other social media platform. We have introduced our membership program, which is absolutely free till 31st of this month. And in this membership program, you will be able to meet the pioneer instructors like Dr. Pallavi and many more. At your demand, this study materials will be sent to you. And the most importantly, that up to 30% of discounts you'll be getting on all physical as well as the digital webinar, workshops, conferences, and all the events arranged by the My Rehab Academy for forever. So it's a lifetime membership. Till 31st, it is open and it's free for everybody whoever wants to join. And our platform is so much technically advanced that once you fill up your information and summary, it doesn't take more than 10 seconds to generate your ID card, and it comes to your own mail. If it is delaying more than that, then it must be your internet problem, not from our side. So coming to today's webinar event, on behalf of My Rehab Academy, I welcome Dr. Pallavi Singh, who is going to take today's session about podiatry, and I'll introduce about her profile. Yeah, Dr. Pallavi Singh, she is the founder for Stride Fitness and Mobility Clinic, Mumbai, Maharashtra, Vice President of Indian Podiatric Physiotherapist Association, Training and Development Head for Heal Institute, Mumbai, Expert Advisor on Panel, Gulf, Get Alive Fitness, Can Innovation India, Ergo Monk, Foot Balance India, Foot Essentials, etc. Axin Medical Certified Practitioner and Distributors for India, Accredited Foot Balance Medical Expert, March 2018. Her certificate in foot and ankle, lower limb biomechanics, dispensing medical grade orthotics by Vaishali Medical. It's there since November 2010. So her profile is quite long, and I'm very happy to introduce her in our panel, where she will be able to let you know how to make the specialty clinic. Guys, this is the problem in our country. We have physiotherapy clinic. Whoever you ask, okay, we have a physiotherapy clinic. You have back pain, foot pain, knee pain, shoulder pain, neck pain, anything you come, we'll do it. No, we have moved much ahead. If you go to the advancement of the physiotherapy field, we have gone much beyond. So India, we want like a Western country, we should have this specialty clinic. And I'm not saying you to open up a specialty clinic for 24/7 for this. No, she will be letting you know how we can open up a clinic which can be specialty for foot at least once in a week or maybe once in a 15 days. It depends upon your convenience. But for that, you need to know what is the specific assessment and physical therapy techniques to be introduced for these kind of patients. If you remember, 2 weeks before, we had a webinar on vertigo clinic. So how you can make a how can you convert the clinic into the vertigo specialty clinic? That also once in a week or once in a month or once in a 15 days, whatever your convenient goes. So guys, now we have moved ahead. Now in this age of artificial intelligence, we cannot be a normal physio. Just anything is there, ajaiye, we will do it. Not like this. Now something we should be very special and taking our country's pride at highest point. We should be so much specialized that we must be able, in fact, we must be able to put the paper in every specialty areas. So Dr. Pallavi Singh, on behalf of My Rehab Academy, I welcome you, and I'm very glad and delighted that you are taking classes on such auspicious day. And I'm sure that guys will be benefited from your course, and they'll be very much able to use their expertise in academics as well as in clinician part.
Thank you so much, Saurabh. It is really nice to see you all on a Sunday morning, especially on Dashera. So first of all, happy Dashera to all of you. People like Dr. Saurabh and the whole team of MRA is something that I really admire. India for a very long time is struggling to make its name in physiotherapy arena. Though we have a good amount of highly qualified physiotherapists, but because we are not in the business of making us a specialized, one of my ex-boss used to tell me that sometime a physiotherapist is like a samundar ka vyapari. Whatever comes, they take and they go forward with. I would say that it is not bad in certain ways, nothing to feel bad about. But if you try and focus, body is a very complex structure, so many joints, so many muscles, so much to know about. Sometimes it is beyond someone's capability also to treat and do everything. At least for my sake, I couldn't remember much. I couldn't do all the joints. So I stick to podiatry and foot. Kind of easy, but it has really helped me to grow and gain more knowledge and experience in this thing. So briefly, just to introduce myself, I have done my physiotherapy in 2006 from Indore, and then I was in fitness industry for 3 years. I was managing a branch of Gold's Gym and Tilwakar Gym in Indore, Jaipur, and then briefly I worked for 4 to 5 branches in Mumbai also. My specialization was basically system setting and administration. So I worked on a lot of things on that regard. Then when I moved to Mumbai in 2010, I was approached by a company which was basically importing footwears and insoles and diabetic shoes, along with belts, braces, and support of premium quality in Mumbai. So when they approached me, they were looking for somebody who can develop a system around and sell those things through clinical basis. So I was not very sure that what to do. So they asked me that Mr. Philip Wesley, who's an Australian podiatrist, is coming next month. Why don't you attend their workshop? And there I was introduced to podiatry for the first time. So from that time onward, I started developing interest in foot, and so much complex and so much easy to treat. I was not knowing that fact before. So then later on, I started self-reading because he came and obviously 2 3 days we got a little more time because he was here on a trip of going to different cities. So we were there in Mumbai, Ahmedabad, Hyderabad at that time. So it was a very enlightenment kind of a trip for me. We learned a lot through him. And then we started seeing the patient. I developed the whole clinical aspect of it. And then in 2014, I started my own company, still as a franchisee of the previous company I was working. And then in 2017, I became an importer for the products directly. After 2017, I have empowered more than a dozen clinic as an associate. So I have taught and teach and make them start their own specialty into foot. So they are now giving insoles and footwear to their uh, patient directly without my involvement and everything. So that is kind of an achievement. Another thing what happens is when a physiotherapist start two things together. One thing is your passion, you treat your patient, you evaluate and do everything. And second thing is you start making money out of it. So I will explain these aspects to you in the later half of the presentation. Just a quick check. You all will be comfortable in English, or if I drop to Hindi sometime, it is okay. Is there anybody who has no understanding of Hindi? They can just unmute and tell me. So I consider that everyone is okay with Hindi and English both. Okay.
I don't know Hindi.
Can I get your name, please?
Richard.
Okay, Richard. So I will not drop too much into Hindi. The only thing is that if there is something complex, learning in your own language sometimes is easy. For my fault, I just know Hindi and English. So I'll try to stick with English more. If there is anything which is giving you trouble, we have 5 modules in this. After every module, we'll have 5 to 10 minutes break. And before I start the next module, if there are one or two specific questions, you can drop it in the chat box, and maybe we will address those questions before moving on to the next module. Now, the way I have designed today's course, I do prefer to do more physical training rather than online training, but in the present scenario, this is the best case possible. So I try to include a lot of pictures to explain things. If you really want to understand what is wrong with the foot, you need to understand what is the normal for a foot. So we will be focusing more on the normal aspect of the joints rather than the pathological aspect, because any deviation from there is something that you have to biomechanically evaluate and treat. So our focus will be on, in the first half, we'll be focusing on what are the different structures, how they work with each other. Then in the second half, we'll be dealing more with the treatment part, what is need to be done, how it is need to be done. The solution is really simple. If you focus onto the first part of the presentation, you will know what to do in the second part. Dr. Saurav has already told you about that you need to be focused for 70%. I would ask 100% and 200% from you, because this is not something that you see and do on a regular basis. So try to have maximum focus. While I'm giving the presentation, I will be giving you some clinical insight on the slides, that what you see when we are talking about ankle motors, what happens with that in a clinical examination. So try to grasp as much as possible. The recording, I think, will be available for you, so you can go through that. But the more you learn in person, the focus on the second time is not there. You think like, I know half of the things, so you will skip the important part later on also. Okay, so let's start with the presentation. Is anything else, Dr. Saurabh? Shall we start? So the course that is upcoming, it has all the things that can be used by a podiatrist or a physiotherapist or chiropractor or osteopath or people who are using orthotist and prosthesis. So these kind of the knowledge that I'm sharing right now is useful for everyone who is in these field. Um, I just let you know about my conflict of interest in this thing. As a company, Stride Fitness and Mobility Clinic, I'm an importer of Exin medical footwear. So I will be giving example of Exin medical footwear in my presentation. Uh, that is for the ease of doing the presentation and the availability of the products. There are many products in the market which I would not use their name or say anything about it. I will only focus on Exim medical footwear and the things that I use personally in my clinic. Other than that, I'm not covering it today in the presentation because of a lot of issue with infringement and problems related to legal issues. So very first part of it, the first module will be focusing on the anatomy and the biomechanics of the foot and ankle joint. Why foot is so important for me? So very first thing, this is, I would say, like the biggest thing that as a human we have achieved is standing on 2 feet. So bipedal stance, if you see the whole history of human development, is the biggest thing that has happened. Now, when we are standing on our 2 feet, there is some advantage and disadvantage. So we got our hands free to do a lot of work, micromanagement, and activities like cooking and all those things that way we feel like we are human. But the biggest disadvantage of bipedal stance is the stability part. So when you are standing on 2 feet, the stability is compromised. And whatever we are achieving, the biggest advantage and disadvantage comes from the foot. So if you talk about the foot, about 25% of the bone are there in the foot itself. Okay, we have heard about the Achilles tendon. That's the strongest tendon that we have. The most unique thing about the foot is in a part of grade cycle when we are in the last stage of contact phase and going about toe off, then at that time our body is boring like about 4 times of your body weight. Okay, so such a small toe joint, the first ray is taking 4 times of your body weight. So that's a very unique capability of body to withstand that much of load and on such a small structure. Um, and that is why we can see ballerinas dancing around on their toes. Another thing that is very unique about the foot is its adaptability. We can walk on sand, we can walk on hard surfaces, we can walk on uneven surfaces, and in all those we can do it with ease because of the locking and unlocking mechanism of the foot. So we'll discuss about that in the coming slides. Our foot is working in a 3D manner. Okay, so we are crossing various plane for one single action, which most of the joint in the body are not doing. But foot is constantly in the three-dimensional space to do any action. When we are talking about foot problem, it is common in all ages. As per the medical data and research available, 80% of the population suffer from one or other foot problem in their lifetime. And out of that, if we see, female are the one who are suffering more as compared to the male audience. The reason for that is the broad pelvis. So it is again a disadvantage for the foot because of the broad circumference of the pelvis. There is a lot of shear forces that are coming onto the foot. Kids are very vulnerable to malalignment and developmental issues because of the fact that their bones are soft and pliable when they are young. And if the kid start walking earlier or in a wrong posture, it is little difficult for it to be treated in the near future. For the orthotic correction, what we do is first 2 years we wait for the kids to stand on their own and choose their way of walking. After 2 years, if we see that mostly around the age of 4 to 5 years, we actually start. Am I audible? Yeah, so at the age of around 4 to 5 years, we start the orthotic corrections in them. Because it's an external device, we can control the angles at various joint to give optimal posture to them, the way they are standing and walking. We can manipulate that with the help of insole in a good way. Now, if we talk about foot as a structure, we have 28 bones in the foot, including the two sesamoid bone under the first metatarsal. There are about 33 joints these bones are making with each other. More than hundreds of ligaments are there, intrinsic and extrinsic muscles are there, which gives the foot a very strong structure to withhold whatever weight we put on it. Somebody with the same height can be of 40 kg, and somebody with the same height and frame would be of 140 kg, but foot withstand everything. And that is all on the bones, ligaments, and the intrinsic muscles of the foot. We divide, for the sake of a study, we divide the foot into three different parts: hind foot, midfoot, forefoot. Uh, Okay. So foot as in structure, in general, if we are talking about the major function of the foot is weight bearing, giving us mobility. This is the only way that we are moving from one part to another. It helps in transferring or reducing the ground reaction force. Imagine if we take Newton's law, towards every action there is equal and opposite reaction. If your weight is about 100 kg, then 100 kg ground reaction forces are acting on you. Now that much force from top and bottom, if the joints like knee is taking that, it will crush. So you will get like a knee arthritis at the age of 20-25. But because of the fact that foot is there to do the shock absorption, specifically the plantar aponeurosis is something which is doing that. We are not having that much shear forces on our other joints like knee, hip, and spine. Another thing that it do is say in case of less important use, if somebody is having a hand deformity or amputation or something like that, foot can replace hand also. Um, so this is how we divide the foot. The forefoot consists of phalanges and metatarsal. Midfoot consists of cuneiform bones, cuboid and navicular. And hindfoot is basically the talus and the calcaneus. These are the position of bones. If you see in the skyline view, muscles and all will work later on. So what is an ankle complex? Okay, so ankle joint is not a single joint but a combination of three joints together. First is the distal tibiofibular joint, talocrural joint, and the subtalar joint. We call ankle joint as ankle mortise also. So what is a mortise? In the carpentry world, this is how a mortise is made. So this is a block of hole, and this plank can go inside and make a joint. So same way, the ankle joint is made. That's why we call it as a mortise, specifically the talocrural part of it. So this is the distal tibial. This is the distal tibiofibular joint. Yeah, this is the distal tibiofibular joint. This is the talocrural joint, and this is the subtalar joint. I'll explain you in coming slide how it goes. If we talk about the type of joint, in broad senses, it's a synovial hinge joint, which is a uniaxial joint. The articular surfaces are tibiotarsal joint, distal end of tibia, medial malleolus of the tibia, lateral malleolus of the fibula, and body of the talus. These all come together to make the ankle complex. The ligaments of importance here are anterior talofibular, posterior talofibular, calcaneofibular, deltoid, tibiocalcaneal, tibionavicular, tibio-talar part, and then the fibular collateral ligament. So these are all important ligament, and these injuries which happens in these joints can be of grave danger. Now, very first, let's focus on the subtalar joint. Okay, I'm covering the important parts of it because these are the joint which comes in physical examination. You can find out if you see any instability or deformity in these joint, then you know that something is wrong with your foot. So in the subtalar joint, the articular surfaces are talus and calcaneus. It's a synovial or a plain synovial joint. Now, the main function of it is to cause the movement. So you understand the concave convex rule, I hope. If not, I would not be covering it today, but you do study the convex concave rule. So major function of subtalar joint is provided by the stability component. Now the stability for the joint itself is through the joint capsule, the ligament, specifically the posterior talocalcaneal ligament, medial talocalcaneal ligament, and lateral talocalcaneal. So these three head of posterior, medial, and lateral talocalcaneal ligament gives like a complete compact structure, and the ankle joint is more stable over here. An additional ligament is the interosseous ligament that acts as a bind for talus and calcaneum. So you can see in this, I cannot see myself, so it's okay. So this is the calcaneum, this is the talus. They have joint surfaces. So there are three surfaces on the talus and congruent surfaces on the calcaneum. So posterior, anterior, medial. So from 3 points, they are joining to each other. Now, another thing that is of important in talocalcaneal joint, the axis. Okay. Now, this is sitting in a oblique axis. It is not horizontal or something. It is an oblique axis. So, अगर आप देखेंगे, so the talar head is so this is your superior end. This is your inferior end of fibula. So they are in a oblique axis. Now this oblique axis is important to do plantar and dorsiflexion. If we are not having this oblique axis, we will not be able to do this thing. Now if we talk about neurovascular supply, it is supplied by posterior and posterior tibular and fibular artery both. Now, if there is any injuries of that thing, you will be having a lot of pain in the medial side of the foot and the structural deformity that comes with that. Just a second. Now, the second joint of importance is talonavicular and calcaneocuboid, which is the mid-metatarsal joint. They are also called as Chopard joint. Okay, you can see in picture over here the red mark. That is the mid-metatarsal joint. Now, the mid-metatarsal joint are basically there to give us shock absorption. Okay, whenever we are standing on the feet, the aponeurosis or the plantar fascia and everything, they work like a trampoline. Your body weight is transferred to it, which gives you expansion and stability at the same time. And then when you release them, you go into normal standing position. Now, the other joint that comes in action is the Lisfranc or the tarsometatarsal joint. Okay, it has three components: medial, middle, and lateral component. So that is the medial component is with the first metatarsal and medial cuneiform. The middle component is second and third metacarpal metatarsals and intermediate and lateral cuneiform. The lateral component is fourth and fifth metatarsal with cuboid. So these are like three sections which are there, which helps the TMT joint to function. Now we come to the MTP joint. Okay, so this is between the metatarsal head and the interphalangeal joints. Okay. Now the most important structure over here is the first ray. So as we were talking before. The first ray is basically the first metatarsal and first cuneiform. Okay, so whenever we are standing and walking, our body load is taken on the first ray. Okay, uh, about in normal standing also it takes about 40% of your body weight. The muscles that work for this is tibialis posterior, tibialis anterior, and peroneus longus. These three muscles, if any of it is injured, you will see flattening of the arches or deviation in the first ray. It could be in the form of a bunion or crisscross toes, or you will see hammer toes and all. We'll cover the foot deformities later on. The main function of the first ray is to resist the ground reaction force. So that is where the shock absorption part begin with. It allows the first metatarsal head to plantar flex at heel lift. So when we are in this position, if you see, this is how the first metatarsal can take the load because the locking of first ray is happening. It maintains the medial longitudinal arch. Okay, so whenever we are going, when we are covering the gait, we'll cover in detail how the foot acts in different gait cycle to give you the stability and function. But first ray is something which is theoretically very much important when we are working on the insole part and the correction part also. For physiotherapy point of view, you should be aware about helix limitus, helix rigidus for knowing the first ray involvement in that. If we have a hypomobile first ray, then there is a good chance that we will develop a lot of foot ulcers, callus, and corn in the feet. If we have a hypermobile first ray, then we will be having helix valgus, plantar fasciitis, and other foot deformity like pes planus also. So, what is the hypomobility and hypermobility? As the term says, if somebody is having to be honest, like if you have a pes callus, so it means that is the foot is in a abnormally high position which locks the first ray. If the first ray is locked, these ligaments are in a shortened position, so you'll be putting the weight more on the heel and the forefoot area. So there is a good chance that you will develop the ulcers at the forefoot under the first ray. If you have seen diabetic patient with diabetic wound, this is the zone where they develop maximum pressure. So they cannot do a proper gum clearance due to lack of shock absorption in the mid metatarsal joint, and then it transfers to the first entity. When we are talking about hypomobility, it means that the first ray is downward. The ligament is too long for the bone to hold in its position. Due to hyperflexibility, you will first see the flexibility increasing the foot drop in terms of arch drop. And then what will happen? These ligaments are, the first ray is taking the load, so the first ray start turning inward. As the age advances, as much as you are having the navicular drop, the bunion will increase. That is a not functional helix valgus, not a structural helix valgus. A structural helix valgus is there since birth, or it's a heredity factor. Uh, if there is confusion, just let me know. I'm entering the most boring or a little sleepy part of foot and ankle, which is axis and plane. Uh, so in short, we need to understand the axis and plane for the sake that while we are doing the examination, our eyes, like we can use the softwares, but we can train our eyes to be a slicer and dicer. If you know the axis and plane, you know where to cut the body in slices to understand what part is not working with what part. Okay, so that is the purpose. We know about the axis of any joint is different than our body axis. So for foot, we definitely need to understand those axes for the purpose that they are angulated. They are not like a straightforward joint. So we have in the lower limb, if we are talking about the axis of lower the femur, it is at the center of the head of the femur to the center of the top portion of the tibia. Now, if you are talking about the tibial end, it is start at the apex of tibia and goes in the center of it. That is the mechanical axis. Then we have our uh, anatomical axis also. So if you are talking about the normal value, you might not remember it, but just it is a medial deviation of 4 mm is there, to 10 mm is there. So in that range, if the femur is going a little outward, at this is okay. But beyond that, we have to see what is happening. So when a person is having a greater lateral deviation, then it means he is going into genu valgum. And if he is having an increase in medial deviation, then it is genu varum. Okay, just a second. So you can see in this X-ray, this person is going into, nobody can answer. So this is X-ray which is showing deviation at the mechanical angle where the tibia and fibula are going onto the lateral side. So this is a case of genu valgum. Now, when we are talking about the anatomical axis, then it is measured from the tibiofemoral angle, that is the upper acute angle formed by the anatomical axis of the femur and the tibia. The normal values for it is, the angles that can variate is 6.85 to 1. So 1.5 degree, if they deviate, it is okay. Physiologically, they are into mild varus, so that you have to remember. When you see the leg, there is a lot of confusion when somebody says, I'll tell you the clinical aspect of it. If you see a person with overpronated foot, ideally as per the theory, the foot goes into internal rotation, and there will be the deviation towards knock knees. But sometime what happen, people compensate. So instead of overpronated combination with a knock knee, you will see a knee going outward. Now, why this axis are changing? It's what important when we are doing the clinical examination. So why they are compensating by hyperextending the knee? That is something which is unique to these kind of cases. uh, Planes I still have to tell you. So if you are talking about the type of joint in the ankle and foot and their planes and motion, then first comes the talocrural joint. It's a hinge joint, works in the sagittal plane, dorsiflexion and plantar flexion are their prime action. Then comes the subtalar joint. It's a condylar joint, mainly transverse plane में काम करता है, otherwise it goes into sagittal plane. The action that it performs is inversion and eversion along with dorsiflexion and plantar flexion. Then comes the metatarsal joint. It is talonavicular and calcaneocuboid. The talonavicular part is ball and socket. The calcaneocuboid joint is a saddle joint. It works mostly in the transfer and the sagittal plane. Again, the actions are inversion, eversion, flexion, and extension. Then we come to TMT joint, that is a plane joint. MTP joint is a condylar joint, sagittal plane and transverse plane. Again, it helps in flexion, adduction, abduction and adduction. And the interphalangeal joint are purely the hinge joint, and their action is only in the sagittal plane, which is flexion and extension. So this is how we are slicing and dicing the body. Always remember why we do so. थोड़ा boring लगता है, but the major important of this is to see the similarity between the right and the left half of the body. So you first do the examination in the sagittal plane. When you are observing a person or a body, observe in the sagittal plane first, see where the shoulders are, what is the hip level, what is the ankle level, and then you go into the frontal plane. You stand on the side of the person and see if the spinal deviations are there, like a compensatory anterior pelvic tilt or a kyphosis or a forward neck posture is there. And in the transverse plane, what you are trying to understand, it's not only for the body but for the whole joint. So between the right and the left side, if the knees are not in line, that means there would be a chance of LLD. Then you will do further examination to make sure that you come to a conclusive diagnosis. If you are talking about the main action that the foot perform, it's plantar flexion, dorsiflexion, abduction, adduction, and inversion and eversion. So what we'll see. If you are talking about pronation, pronation is a normal function of the foot. Overpronation is a biomechanical issue or a problem that need to be addressed. So pronation we don't need to address. Pronation is a combination of dorsiflexion, which is happening in the sagittal plane, eversion that is happening in the frontal plane, and abduction, which is happening in the horizontal plane. So this is how the triplanar motion control, orthotics and everything is designed. Because if we are having a problem like a flat foot, and we go for insert, which is just a heel raise or a arch support or a medial raise, it will not work, because all three planes have to be addressed and adjusted accordingly. Otherwise, if we talk about supination, it's a combination of plantar flexion along with abduction, adduction, and inversion. So again, triplanar motion. Both supination and pronation are part of normal gait cycle. So we will not be calling it as a pathological problem unless and until it is off to certain degree and their other motion is compensated. So if you have a supination but no pronation while you are standing and walking, then it's a problem, and then we need to address it. How to do that we will see in the coming slide. Again, for your understanding, these are certain figures which will help you understand how the joints sit on each other. So this is the posterior aspect of ankle joint axis. You can see that what is the tilt? The medial malleolus is high, lateral malleolus is low. The deviation in which they are sitting is plus minus 8 degree. Uh, Now, if you see from the top view, then it is in slight rotation. So neither it is a straight line nor it is aligned straight at the ankle axis also. So it is tilted and then in an angle. So oblique is what we call it. If we see the subtalar joint axis, okay, it is about 42 degrees superior to the sagittal plane. Now it goes into 16 to 23 degree of medial deviation on the transverse side. The range of motion in pronation and supination is 5 degree to 20 degree, and inversion eversion range of motion is 30 degree to 18 degree. Mid metatarsal joint we can skip. What is important in mid empty joint locking and unlocking? If we don't have, so when the foot hits the ground, we need it to adopt to the surface that it is touching. Okay, so say you are running on a sand, you hit the heel first. Okay, that is the normal gait. Now the foot needs to be flexible. So a metatarsal joint at that time gives you that flexibility. As soon as you go into foot landing and a mid stance posture, the foot started locking, become a rigid lever, and allow you to transfer your body weight from hind foot to forefoot through the first tray, and then you go on your toe, and then the other leg is into swing phase. So that's the most important thing in foot that you need to understand how it works. If we talk about the arches of the foot, there are three arches: medial longitudinal arch, lateral longitudinal arch, and transverse arch. Medial longitudinal arch is made up of three calcaneus, talus, navicular, cuneiform, and the three metatarsals. Uh, every arch has to begin somewhere and end somewhere, so we call it as the pillar. The posterior pillar is formed from the tuberosity of the calcaneum, and so this is the medial longitudinal arch. The anterior pillar is formed from the metatarsal head, and uh, it is supported the bottom of it is supported by the plantar aponeurosis. From the top, the talus is helping it, and then there are the spring ligament, deltoid ligament, tibialis anterior, posterior muscles, and then flexor hallucis longus. So these are all part of the medial component. So we are dividing the foot into two half, medial and lateral, and then the transverse is over here. Okay, the lateral is again opposite to medial. So in this view, you can see the talus, naviculum, medial cuneiform, and first metatarsal. That is the structure that is making the, and calcaneum from the bottom. So that is making the medial longitudinal arch. Now we are talking about the lateral longitudinal arch. So lateral, again, calcaneus, talus, cuboid, metatarsal, phalanges. Okay, lateral, if you see, in most of the normal foot, you'll be able to see the lateral arch. In most of the pathological foot, the lateral arch is either flattened or not there. In supinator, it is prominent. Normally, it is little over there. If you see flattening, it's a flat foot with supination, and high arch, you will see a more elongated longitudinal arch. Again, uh, the pillars are the calcaneum. Anterior pillar is from the metatarsal head of fourth and fifth metatarsal. Again, the plantar aponeurosis help, long and short plantar ligaments help, and lateral longitudinal ligaments that will help. Peroneus longus is the main muscle around the lateral arch. So this is the structure. Sorry, I'll show you the lateral arch on a foot which has the skin on it, so you can understand much better. Then the transfer arch. The basic function of transfer arch is to connect the medial and the longitudinal arch. The transfer arch is basically the metatarsal bones that we have talked about. So if we don't have a good transfer arch, we don't have a good ground reaction forces. So sometimes when you see a person, you will, so this portion of the foot, first thing, is called as instep. Okay, all the metatarsal bone. In a flat-footed person, these are in a downward position. So they are collapsing down due to over flexibility and unlocking of the joint, because the plantar aponeurosis is not holding it strong in the place. In case of high arch people, the instep go upward. Now, when it is going upward, it is in a rigid and locked position. So people with high arch will have more compression onto the lateral structure as compared to the medial side. People with low or flattened transfer arch will have pressure on the medial longitudinal arch. One of the unique function of the foot is the windlass mechanism. For your understanding, windlass is something that you see when you see like that anchor in the ship, how the anchor they roll it up with a chain or a rope kind of a structure. So it pulls the anchor up. So no matter how heavy is the anchor, you imagine that such a big ship is grounded onto the seashore with the help of that anchor. So that small structure can hold the whole foot. So our plantar aponeurosis and the structure of the foot is the anchor of our body. We are walking, standing, and doing everything because of the windlass mechanism that we have in the foot. Windlass mechanism is also a diagnostic tool for us to see whether the deformity in the foot is temporary or permanent. So how we activate the windlass mechanism: when we are making a person to flex their toes up, ideally the arch should go in a normal position or a tight position. Whenever we are tightening up the plantar aponeurosis, the arch should go up. So if it is going up, the windlass mechanism is intact and the foot deformity can be corrected when we are doing the clinical examination and correction. If we see no change in the bone, like if say somebody is there with a navicular drop and you ask them to flex their toes up and you see no movement happening around the navicular area, then it means that the person is having a structural deformity without much scope of correction. So you will only make it comfortable for them to stand and walk. You will not try to change the alignment in future. Let's talk about the gait cycle. Okay, so it is basically divided into two. 60 to 40 is the ratio. 60% of our time we spend in touch with the ground and 40% in air. There are two different nomenclatures that we use. So earlier, we in the classic format we used to say heel strike, foot flat, mid stance, heel off, toe off, mid swing, and heel strike again. So that was one gait cycle before. Now it has been converted by RLA into a new terminology in which when the heel touches the ground, we call it as initial contact. Then there is a loading response when the body is coming from behind to middle, and that is the phase where you have the loading response. Then you go into mid stance, where one foot is in total contact with the ground and other foot has started to go off the ground. Then it comes into terminal stance, where the foot in the air started touching the ground again. Then there is pre-swing, initial swing, mid-swing, and terminal swing. So this is the heel strike phase. Uh, Now in this, there is a lot of ground reaction forces that is acting at the posterior part of the heel. When you touch the heel first, your foot is into slight supination. Okay. In the second phase, when you start going forward, 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 then your foot goes into pronation, takes a little landing on the feet. The body balance itself with the help of a good arch without dropping it inward or outward. There is a stable stance in mid phase, and then you move forward to the swing phase, where your foot again goes into supination, and then you bend at your knees and goes into. Okay. So in swing phase again, the early swing is 60 to 75%. Then 75 to 85% you are into mid swing, and then late swing is 85 to last few this thing. In the late swing, the hip is flexed between 25 to 30 degree. So that is important to see how the foot is so when you're doing a gait examination, it is important to see the static and dynamic, both the aspect. In static, we are talking about the foot which is in contact, and also the foot which is off the ground. Sometimes people focus only on the foot that is walking. So the gait analysis, when you are doing it, has to be 3 to 4 minutes, and you have to observe each leg individually, and then how each leg is acting with each other in respect to each other. So if we talk about the abnormality of gait, the most important is the overpronation part. Excess overpronation during the gait cycle is we can make it out when the foot rolls too much inward, and the toes are deviating into adduction. So if we do see a person in static alignment, a normal person, when we are seeing them from behind, the center of the heel, the Achilles tendon, all should be in one straight line. If we draw a plumb line also, it should be in straight. If we see somebody with mild overpronation or pronation, this is the deviation that we see. In severe overpronation, these two angles don't match. So you can draw a straight line from the center of the calf to the bottom, and then from the center of Achilles towards the center of heel. The more this is, the more is your problem. Now, if you are talking about the closed chain kinetic implication of this thing, when a person is in overpronation, the calcaneum is into eversion. The foot goes into adduction with plantar flexion at talus. The medial rotation of talus is there. Medial rotation of tibia and fibula over here. Then there is a valgus at the knee. Okay, in theory it is like this, but in practical you might see it different. How they compensate on the knee depends on the integrity of your core muscle, your hip, and then your quadriceps. So all these three can change it to this also. But ideal case scenario, when there is a overpronation part, then you should be seeing an internal rotation of the tibia, knee valgus, internal femur rotation, and pelvic going into a little rotation, which is causing the pelvis to go into anterior rotation. Now, if somebody is into supination, then the opposite happens. The calcaneum go into inversion. So you'll see the heel going in inversion from behind. Abduction and dorsiflexion of talus happen. Lateral rotation of the talus, then lateral rotation of tibia and fibula. Knee goes into varus. So you could see a bow leg kind of a deformity or a hyperextended knee when you are seeing a person with a supination. There is lateral rotation of femur and the posterior pelvic tilt is visible. So posterior pelvic tilt might not be easy to see. What you see is flattening of the lumbar curvature. So while examining that kind of a foot, you will see that. Now, what can actually cause overpronation or supination? There is a lot of debate, but two things can happen. One is you are born with it, and second thing, you develop it. So when we are seeing somebody with a flat foot, a very flexible flat foot, never having any pain and discomfort in past, then what we can say, this is most likely a congenital flat foot. They are born with over flexibility of the plantar aponeurosis. Now, if we see somebody with uneven flat foot, say one leg is proper or slightly deviating down, but the other is completely flattened out, even the navicular drop and drift is present, then it means that these are adult acquired flat foot that can happen as a chance of injury, medial collateral or lateral collateral ligament sprain or rupture. So that can also cause these kind of a thing. Other factors are obesity, wearing uneven shoes or too flat a footwear that is not supporting your foot structure. Sometimes people wear shoes which are too tight for them. So all those things, poorly compensated midfoot can also cause the flattening or the supination of the foot. Other factors in female specifically would be post-delivery. There is a release of relaxing hormone in your body, which makes the ligaments more flexible than before. Sometime that is there for a couple of months or year. We never know it for sure. But the relaxing over the period will give them a lot of swelling in the feet during the pregnancy, a combination of lack of exercises, too busy in their routine, standing and doing all their work with an increased body weight can also lead to flattening of the arches and overpronation. Some people who are into running a lot or who are into heavy weight lifting, they also develop a collapse arch over the period. Now, what could be the possible issues that can happen due to flattening of the arches? That are plantar fasciitis, Achilles tendonitis, motor neuroma, tough toes, shin splints, and hallux valgus. We will cover those in detail in the second module. New shoes, if we are talking about, we can get chondromalacia patella, IT band syndrome, knee arthritis over the period. Then we can have leg length, spinal deformities like low back pain, spondylitis, uh, SI joint dysfunction, what you call as sciatica happening often. Those are all some, related to the back foot alignment. So with this, we'll end the first module for now. Any questions or doubt about it? You can unmute and we can discuss. And then we'll take a quick.
Kindly unmute and ask questions. Dr. Pallavi, she is ready to take your questions. Before she proceed for module 2, she is asking questions from you. If you have any question, you can unmute yourself and can speak. Rather than writing on the chat, it will be always good that if you interact verbally, she'll be able to understand your problem better. So please unmute yourself and ask a question.
Good morning, ma'am. This is Dr. Rainy Dorcas from Indore. I have a
Please go ahead. Please go ahead.
hello. Am I audible?
Yeah.
Yes, very much, ma'am. Please go ahead.
Yes, please. I would like to know the difference between the navicular drop and drift.
So it is easy to tell that on a in physical training, but your navicular bone, when you stand and say there is a over flexibility of this joint and your navicular just drop down, okay, then it's a navicular drop. When somebody is standing and while it is going, the whole structure is rolling inward, dropping and shifting forward, that is called as navicular drift. So mostly people who are born with a flat foot are more over flexible. So and if you see like rigid foot, so if there is a 4-foot abduction, the foot is completely going into lateral deviation. The more it goes into lateral deviation, the navicular will drop and drift. So in your normal foot, so you're standing, your body is going into flattening with deviation towards the lateral side. So there will be a drift. If the foot is just dropping or rolling inward, there will be a navicular drop. There will be a increased pressure under this area. You will see corn calluses developing around this area under the foot. Hard skin you can see here, and you will see a hard skin on the toes here. So that is the area where the body is taking the load. Over here, all these structures are dropped down. So in severe overpronation and structural flat foot, you will see more of a drop with a drift. Now, how to check it? What you do is you make the subtalar joint go into neutral position, and that will give, if it is a flexible one, the naviculum bone will go up. Now so how you take the subtalar neutral? So you make the person stand in front of you, then you palpate the subtalar joint, push the medial side of the foot in the center. If it is a flat-footed person, push it in the medial side, and then you will see the navicular coming up. Take your hands out and the navicular will drop. So when it is in a corrected position, take a pen in the center of the navicular. Okay, so keep the pen. You can keep a paper underneath. Okay, so take a pen, draw a spot on the paper when it is in subtalar neutral position. Then let go the subtalar neutral. The foot will start dropping and dragging forward. Then there will be the second spot where the navicular is going. So you can put a point at that. You can take the center point of naviculum and do a dot over there, or you just imaginarily take that pen and put it parallel to the center of the navicular. Now, if it is 1 mm and more, okay, so 1 mm is common. If it is more than that, then it is a drift.
Okay.
A small deviation is not a problem. A major deviation of 2 to 3 mm would be a big problem.
Okay. Okay.
So
Anyone else?
you can measure it on the paper after drawing the two drop.
Okay. Thank you, ma'am.
Anyone else?
So
I think, ma'am, we can.
Yeah, so anatomy part is basically little boring, and you already have done it in the past. Still, I would say go and revise it. There are certain things every time you study, you will see something new or new information coming. And the more you read, the more you get the hack of what muscles, what nerve, or what ligament are crossing these joints. And it becomes easy for you to make a diagnosis depending on the injuries that can happen to that area. Some injuries are common towards medial side, some are common towards the lateral side. So if you just remember that, it becomes diagnosis easy and more precise. So Dr. Saurabh will take like a 5-minute pause.
Yes, sure, ma'am. Sure. We'll break for 5 minutes, and then now it's a 10:35, 37 in my watch. So maybe exactly after 5 minutes, you can carry on, I think, with module 2.
Yeah.
So yeah, guys, we can break for 5 minutes.
So you all can turn off your camera, and if you want to move around, just do that.
Yes, sure. Thank you.
basically the anatomy and this thing, though the most essential one is over. Now from onwards, I will try not to make you sleep or feel like you're wasting your day on a Sunday. So we come to the clinical examination part. What I follow is principle of look, feel, and move. So whenever we start with an evaluation, the very first part is history taking. Make the person comfortable with you while you start the initial interview. Talk to them about what are their presenting complaint, what is their visual analog scale in terms of the pain, what they are feeling, where they are feeling, what kind of a pain they are feeling, and since how long they are having that particular pain, what kind of treatment they have done in the past. It gives you a lot of insight about the person, their mental status, what they are looking forward, and what they expect from you. Because if you don't know and you suggest the same thing what they have tried before, like they have been to another physiotherapist and their major complaint is plantar fasciitis, and you again start doing ultrasound and all those things, they will lose hope because they have already got it done with somebody else and it didn't work for you. That's why they are here with you. So history becomes a very important part in deciding the kind of treatment that you're going to take further, specifically if you are calling yourself a specialist in any field. So you should do above and beyond what others are doing. Now in terms of getting it done, so you develop a good rapport with your patients, and now you will start doing examination, which is like an investigation. So you become a detective and you will try to find out the root cause for their problem. So very first thing is you make the person comfortably stand and expose the part that you want to examine. So say in case of foot and ankle, you at least need to see the knee when you're examining the foot. So ask them to roll up their trouser, or if they are coming in a formal attire, keep some shorts handy in your clinic and ask them to change into a short so that you can see you can visualize their angle of the femur, tibia, fibula, everything, and along with the ankle. So provide them a shot and ask them to stand in that comfortable. Have 2-3 sizes of it. It should not happen that there is a fat person and you are giving a medium shots to them, because they will get more uncomfortable while standing and walking. So these are very small things but matter a lot when it comes to your interaction with the patient. Once you have exposed the person to the area that you are showing, what you look for. So you look for any scar tissue, or if there are any burn marks or skin reactions, some kind of changes that are visible in diabetic foot are glossy skin, lack of hair around the area where the peripheral neuropathy has already set in. You will see some surgical marks also. So sometimes the whole examination, while we are taking the history and everything, they are talking too much about the foot. They forget to even mention that they have got some ACL tear repair, or some people have a knee replacement also, and they just don't tell it because it's 20 years back or something like that. So they forget. Specifically with the geriatric, that they don't think it is important to tell you about the old injuries and fractures and other issues. So when you expose them, you will see certain things like that, and then you can again ask them what has happened, when it happened, what kind of a treatment you have taken, because it's quite possible that old injuries can be the root cause of present problem. Then what you see is about the muscle wasting. So in muscle wasting, there are two things. When you are talking about foot, the problematic side is something that you don't put weight on. So muscles might be a little wasted on the side that is basically affected, but the pain complaint can be on the side which is used more. Okay. Now try to understand, if I'm having a flat foot on the right side, what I will do is every time I'm standing and walking, I'm having a lot of pain on right foot. So I will be putting the weight on the contralateral side. Now the contralateral side will have more developed muscle over the ear, but the pain can be on that side because that is the one which is used. So using Eura, that will not give you pain. So one that is used will give you the pain. So it is not that the healthy side would be the affected side. With foot respectively, it happens. Then You will also see how they stand and walk. Do they use any assistive device, or do they wear any braces or support while they are doing the walk? So when you're doing the history part of it, and you don't expose the knee, they might be wearing a kneecap. Then once they remove the kneecap and all, you can see for what is there in the knee, what are the sign of compressions and all are there. If they are wearing too tight a brace also, the sign of compression will be visible onto the foot, and you can onto the knee, and then you can understand that the blood supply towards the calf and ankle might be compensated if they are wearing the knee brace all day long. So you talk to them how long they wear the knee brace, for what reason they wear it. So you will understand a little more about it. Then the other part comes is what you feel. So in case of say some swelling or something, you will palpate that area and see whether the edema what is there is pitting edema, or a rigid edema, or there is a bursitis sign when you touch. Is it little irritable, or you can check the temperature also. Sometimes there's a lot of warmth on one side, and the other side feel cold on touch also. What we do is we use some IR temperature thermometer also. So it helps in taking the temperature of any particular point. When we touch, we get the temperature of that area. So that helps us in case of diabetic population, we need to be aware of. If there is an undergoing inflammation, like the patient that said that they had a fall a week back, and then the ankle is paining. So it might be possible during the fall they have a confusion on the other part of the body where there is the redness and a swelling, and they are not noticing because the sprained ankle is more painful. So when you touch, you can feel the warmth in that part also. Then you will check the pulses. This is the area where you can check the dorsalis pedis, and the second is for your sorry, the second one is dorsalis pedis pulp, and the first picture is for posterior tibial. Then what you do is you take the person feet in your hand and you try to squeeze the whole mid portion. So you can take, depending on their listing, you try to squeeze the forefoot area to see if there is any pain on squeeze. In case of mortal neuroma, it will be excruciating pain that they will say. Some say that only the compression pain is there. Some would say that I feel the pain behind my ankle or something like that. So you can further go and check around that area what is happening. So any movement which is causing distant pain, you have to then check. Then what you do is you see the Achilles tendon, you will check the area around the subtalar joint, whether there is pain or any swelling. So whatever area they are complaining, apart from that, you will examine the area that you think might be getting compromised due to the bad alignment at ankle. Then the third aspect comes into active and passive range of motion. So you will ask the person to move, that you will see, okay, the range of motion is equal on both the side or not. Then you passively move the joint and check whether it is a functional problem or a structural problem. Sometimes they are not using their joint motion due to some tightness in the tissue. So you will also feel in passive motion if the Achilles tendon is too tight to restrict the dorsiflexion of the foot or not. Then while you're doing this thing, you can give a slight resistance at the end range to see if they are having a stretch pain. Sometime what you do is say in case of foot, what we do is we make the person sit in front of us, or you can make them lie down on the bed, and you check each and every joint and see the mobility between the joints, see that whether the flexibility in plantar and dorsiflexion is present or not. Can the toes be fully extended and flexed when asked to? So you check all those range of motion. So when we are talking about the foot examination, we do it in weight bearing and non-weight bearing, both ways. Then we go for gait analysis, and then we finish it off with the foot posture index. Uh, you can do a proper goniometry examination, or for your understanding, you can do a visual angle examination. For me, what is more important, it is not that There is a range that anatomically important to do it, but the range that we compare is between their own body, right and left. Okay, maybe the anatomical range of dorsiflexion is 65-degree, but on the good side also the full range that they can achieve is 60-degree only. So I will not compare the opposite side for 65-degree. I will compare it for 60-degree. So it has to be near to that or similar to that. So जिस side में pain complaint है and the other side where there is no pain complaint, the difference should be measured between them, not to the anatomical. That is my personal belief in this thing. When you see like a helix rigidus or limitus or any capsular this thing, how you check it, it's a little difficult to tell you on this thing. But what you do is basically you flex the toe and see whether it is going up easily or not. If it is going easily, it's a normal helix. If it is feeling like little stuck, then it is a limitus. So what you do is to see whether it is a limitus or rigidus, you apply a little gliding force, take it up and down 5 to 10 times, like how you do the manipulation and mobilization. So do that and then check the range of motion. If the range of motion is improved after your gliding, then it means that this joint was a limitus. If you do this and there is no change in the toe range of motion, then it is a rigidus. So even after doing the therapy and all, it's not going to change. So the compensation has to be made for this area on the insole when you're making the insole. There's a short video demonstration. Let's check if it goes. So this is how you check the range of motion for the first ray. Then we talk about the subtalar joint. The normal range of inversion is 20-degree and eversion is 10-degree. So 2:1 ka ratio has to be followed. It could be lesser than that or more than that, but the ratio should be maintained 2:1. This is how we check. So for doing the calcaneum examination subtalar joint, you hold the position and just move the calcaneum. See the flexibility, whether it goes into neutral position or not. Again, that is important when you are making the insole for the person. Then comes the TMT joint. Here the inversion range is 30-degree and eversion range is 20-degree.
Excuse me, ma'am.
Yeah.
We can't see YouTube videos.
It's not happening?
No, ma'am.
Okay. Should have told me for the first time. Okay. Now, the very first movement that we have seen was plantar flexion and dorsiflexion. So you make the person on a bed and then you check the movement up and down, compare it on the other side, how it is going. In the second, what we did is to check the calcaneum. So we make the person say this is hanging out of the bed, or you can make them sit on a chair or something, hold their leg from behind. Now try to grasp their feet in a way that it is stable. Only the calcaneum is allowed to move. So then you try to move it medial lateral to see the movement of the calcaneum in inversion and eversion, whether it is locked or it is restricted or it is painful between both the sides, so that you check for the calcaneum. Then for the mid-tarsal joint, what you do is stabilize the foot from one hand from the ankle. The other hand is free to move the joint, and you glide them superior and inferior and check for each joint. So you drop them, okay, up and down, and you check there is a locking or not. If that is locked in a non-weight bearing position, it's a problem, because as we discussed, this is when they are non-weight bearing, it has to be unlocked, and when they are fully weight bearing, then only it should lock. So when you are seeing the person in a non-weight bearing process, it should not be locked. So you will check all the movement and see whether if there is any pain. They sometimes say, so all this intraosseous membrane and all what is there, it might be injured due to the walking or running from this individual. So on touching them, you can first feel the locking. You should be able, now with so much examination that we do on a regular basis, you should be able to know what is a bony lock and what is a muscular lock. So what you can move with resistance is more of a ligamentous or a muscular locking. And if you cannot move the joint, then it is a bony lock. So that end feel, what we call, you should be able to feel in this thing. If you are talking about the ankle range of motion, it is 20 to 30 degree in dorsiflexion and plantar flexion. So first you see the active, when you're doing the examination, first see the active range of motion between both the leg. And then what you do is you hold the calcaneum by one hand and flex their foot. Okay, and then check whether there is a good plantar flexion available and dorsiflexion available or not. Okay, so, and you can give resistance at the end to see if the lateral or collateral ligament is giving any pain or discomfort in any action. Then what you can do is you can do a little inversion and eversion also. So see any kind of neural pain increasing. So you just make the patient go in this position and you resistedly do inversion and eversion to see the neural pathway. And then you will see, so when you're seeing the bottom of it and a person is having a transfer arch issue, what you see from the bottom is the great toe is in a downward position than rest of the toes. So if the transfer arch is not fully supported, the motion is not equal on both the sides. If structurally this is down, it means a lot of pressure is coming on the great toe as compared to the other toes. Now, how to see the valgus and varus stress. So you make the in non-weight bearing position, you should be able to see it from behind, like make the patient lie down on their tummy, and then you can see the ankle from behind. So when you're seeing from behind, how is the foot? Is it going inwards or outwards? So you should be able to compare it with the angle of the calcaneum. In foot posture index, we will cover it in the weight bearing process. So there are pictures that can help you to understand. Then you want to see the windlass mechanism. So you lift the first toe and see whether the arch is coming first ring. So if we want to see the medial arch, whether it is intact or not, we raise the great toe, and if the arch comes up, there is a good movement available at the first ring. And if it is not coming, then it could be hallux limitus or rigidus, which you can confirm by manual examination also. It's called as rupture maneuver. Now you see the supination resistance test. How you do is you make the person stand. Okay. You put your two finger under the medial arch. You try to raise the medial arch up. Okay. If it goes up, it's good. If it is not going, it's a positive test that the ligament are rigid. So for a supinator, there will be a more issue on the medial side. So they compress a little bit on this. Then sorry. Yeah. Then what we do is we do the gait analysis. We make the so if you have a treadmill or something like that, you can make the person stand or run or walk on that. Otherwise, just make them walk in your clinic. Very first few this thing for me, the gait examination is not when you do all this step and then you do the gait examination. The best time to do gait examination is when the patient is entering in the examination room. At that time their body is unaware about anyone noticing them, so their walk is more natural. Once you ask them to start walking in front of you because you are doing the examination, they will start doing all the catwalks, and it becomes very difficult for you to make a proper diagnosis. So what you do is basically give them 2 to 3 minutes to walk. Once they are walking come back to normal, then only you will start observing what is happening. Now what you do when you see, so very first thing is you see if they are limping due to pain or discomfort. Then what you see is how they are landing the foot. So you start from bottom to up. Mostly in physiotherapy we do top to bottom, but because of foot being the main subject over here, we see the foot a little first. So what we see is whether they are having the initial contact at the heel, laterally, medially. Then once they are landing their feet on the ground, is the navicular bone bulging out? Is there an inward rolling of the foot? How is the toe off phase? Whether they are touching the ground completely or they are dragging their feet? Is there a good ground clearance when they are into? Yeah, so it's talk about the tibialis anterior dysfunction. If they are not having a good ground clearance, so toe skating will happen. Then when you go up, then you see the internal rotation of the tibia, whether it is happening or not. How is the knee doing? So in case of severe overpronation, a pure flat-footedness, you will see the knee rubbing against each other or crossing against each other. In case of supinators, you will see an increase going. So a lot of hyperextension at the knee you can see, and the knee is going a little laterally when they are walking. Then the other thing you start looking at is the pelvic tilt. So is there a lateral tilt on each side, or are they are going a little rigid on the hip? So you will observe their buttocks, you will observe the axis of the pelvis when they are standing. So whether the pelvis are in parallel or parallel to each other or not. And then you will see the arm swing. Looking at the arm swing is one of the most important way of knowing if there is a functional leg length discrepancy. So that you have to observe closely, and then you see the shoulder, whether the shoulder level is equal or not. Do ask and do tell them that you are noticing that the shoulder is not same while you're doing the examination. Sometimes they come up that I have ankylosing spondylitis because they have not told you this in the previous history. Sometimes they tell that I had a slap injury, I had a unrepaired shoulder post ligament injury, and also that might be causing the deformity, and it might look like a uneven arm swing, but the reason could be of the shoulder and thoracic spine, not the foot. Now, how to determine whether it is the foot that is responsible? To check the PSIS level. So you stand behind the patient and put both the thumb on the PSIS and ask them to bend forward to touch the toe. And then you see if it is going evenly or there is a up and down position of that. So if it is there, then it means that the cause of leg length is from the leg rather than the spine. The best test for it is called as a scanogram lower extremity. We have little bit touched the anatomical and the mechanical axis for the femur and tibia. So based on that principle, when you take a scanogram, it's an X-ray from the hip down towards the ankle, and they measure both the angles. So they can tell you what is the varus angle of the femur, what is the length of the femur, what is the like segmental length of femur and tibia, and the total length of the leg. So on a digital X-ray, they can do that examination. It's a very good and reliable test for knowing the leg length discrepancy, and that is what I follow. Other than that, the tape measurement and all is available as an option, but it can only give you a ballpark figure whether they have a shortening or not. It can never be precise. The most precise test is the radiological examination through scanogram. Now, yeah, so these are like small things that you can check in the gate. You will, when we are studying as a physiotherapist, we see so many neurological gates that I'm not including in this, because neurological problems are structural issue and their solution has to be on the different platform. What I'm doing through this session today is I'm like little bit skipping the diabetic and the pediatric population, and specifically the neurological side of it. I'm trying to tell you the small things that you will see on your clinic on a daily basis and could be the major chunk in terms of business when we are talking about. Now, what is a foot posture index? So when we are examining the foot, it is more like a subjective analysis of a certain thing that is going this way, that way. But if we want to numerologically turn into a proper diagnosis where we can put a number to it and make an observation of before and after, then we can use the foot posture index. You can always search online the foot posture index and you will get more data to read about it. What I'm doing is I'm just trying to explain you a little fact about it. So this is like a triplanar examination. You will see the sagittal, transverse and frontal plane from different position to determine the foot posture index. So in the very first thing, how you score. If it is on the pronation side, the score is in plus. If it is on a supination side, the score is in minus. Okay. So -1, -2, that is how you go, or +1, +2 is how you go. Say a person is in the picture 1, that is the first parameter of it. So you put your hands on both the side, thumb on the medial side and index finger on the lateral side, and you palpate the subtalar. If you feel the subtalar joint is deviating more towards your thumb, then it is a pronation. If you feel the subtalar joint is more prominent on the index finger, then it is a supinator. Okay. Then for the second this thing, you will go behind and you check the foot in terms of the medial malleolus. So there is always a curve at the medial malleolus when it is into eversion, that is the person is a flat-footed or an over-pronated person, then you will see the curve increasing over the bottom. If it is a supinator, you will see the curve decreasing on the medial malleolar side because the foot is into inversion. Then what you do is you see the calcaneum side. So say if we draw a horizontal line onto the bottom, the surface that the person is standing, and draw a vertical line towards the center of the calcaneum. If it is more towards, say if it is inversion, it is more towards the inner side. It is more towards the outer side in a supinator, and in case of a pronator, it is more towards the inner aspect. So you will see the horizontal line is crossing inward. Then what you see is the talonavicular joint in a standing position. So you're standing behind the patient, and so if a person is standing like this is the area where you're seeing. So this groove will be normal. If you see, there will be like a thumb gap over here. If it is a supinator, your hand will go too much inside the groove. If it is a pronator, your thumb will not be able to go inside. So you will find the bones touching you out. So the more it goes into eversion, the bone is pointing out from here. So you can feel the bone very immediately. Then you will see the congruency of the medial arch. So if I'll in the following pictures, I will show you the normal arch. But again, the term normal in terms of arch, because there is no exact measurement key, the height of the arch from the ground should be this much. Okay, there is no normal measurement of the arch. So it is a subjective thing that you have to understand, that what is normal and what is abnormal. The arch can dip down or go up depending on this thing. But what you can do is, you have done the examination of the foot in non-weight bearing position before. If you have felt the metatarsal is bit tight and the movement is not there, and you see a person with a very high instep. So instep is again, uh, so instep is this portion of the foot. If you see this is prominent and going up, then it is a higher arch without flexibility. And if this thing is flattened, like the foot feels flat from here to here, then it is a flat footed person, where this is a plus score, this is a minus score. Then you see the foot from behind. So ideally, when you are standing from behind an idle foot, you should be able to see a part of fifth toe, nil first toe, or very little part of first toe in a normal individual. If it is a pronator, okay, so what will happen? This angle is increased. So you will see not only the fifth, but the fourth, or sometimes the third toe also. So if you see little, then it is +1. You see more, then it is +2. Again, a subjective thing. Now, if it is a supinator, okay, the foot will be curving this way, not that much, but it will be curving into this way. So what will happen? You will start seeing more of a first and a second row. Then this is -1 and -2. The more you see, the higher you will score. Now, don't make these diagnoses as such on seeing one or two patients. What you need to do is, you will start observing everyone in your family, surrounding, and everything. So once you have focusedly seen about 50 to 100 foot, then you will be able to know what is comparatively normal or abnormal in terms of high arch or low arch. So it takes a little time, but give it, the more you observe, the more you know. Yeah, so this is about the basic examination that we do. Any doubts in that? It is a good time to ask question, because this is the main part of the whole thing. Anatomy and all will not come in action on a day-to-day basis. You can always go back to your books and refer the anatomy. Anatomy, you just need to know what is happening, what is normal and abnormal. But clinical examination is by far the most important part. The more good you are in clinical examination, the lesser you have to invest on buying fancy equipment for your clinic. And it can not only help to treat foot, but also all the other joint. No particular doubt about any testing method or anything?
Excuse me, ma'am.
Yeah.
Yeah, I have a doubt. Then when you told about the palpation thing,
Hmm.
the dorsalis pedis palpation, then what are the changes if a person is having a overpronation foot or a underpronation foot?
So,
What are the changes in the palpatory rate?
So usually if it is bilateral, you will not feel anything. The palpation is done only to check if there is a DVT or any kind of claudication in the foot. So if the blood circulation is not coming well to the forefoot area, then it needs to be investigated. So you will see the pulse, whether they are thready or proper, like how we check the radial pulse, we check the dorsal pulse also, only to determine if there is any the arterial blood flow is compensated or not. Okay, if it is compromised arterial blood flow, it needs to be talked to a vascular surgeon. So in case of varicose vein, or when you see somebody is having a lot of cramp in the foot, they are saying the pain is there in all the movement. Say mechanical pain can only happen in weight bearing position. But if a person is sitting on the bed and then also they are having the pain in the foot, then it could be because of the arterial compensation. So if that is happening, it has to be like a color Doppler test and all is need to be done to make sure that there is no clotting or something else that is happening. So pulses, you check the pulse to determine all those things and refer to the right person before there is a problem. Specifically, you need to do it only in case of diabetic people. Say if you don't have too much of a time to do the whole examination, you will do at least in the diabetic patient. So if between both the side the pulses are different, or some side it is steady and you cannot feel it, then it means that it's need to be checked. But again, to feel the pulse, you need to do it on as many patients as possible, so that you know what is the normal way or area where you should touch to get the best result out of it. Sometimes in obese feet and all, it is difficult to find it. So you should be very precise when you're touching it and how much to put pressure on. Other things, when you are seeing a person with a blackened foot, not the not the type that you see in terms of sun burn kind of a thing, but you see patchy discoloration, black spot coming onto the feet, or the hairs are going, or there is a glossiness, then these are again a sign of peripheral neuropathy. It can be in diabetic and non-diabetic, both kind of a patient. These patient can also be having a little discomfort in the foot while standing for a long time, because then there is a peripheral pooling of blood which is increasing the pressure. So hypertensive people who are onto medicine to control hypertension, they have water retention in the foot. So that could be a side effect of that. And what you need to advise to these patients is, if they have not changed their hypertensive medicine for a very long time, ideally they should visit their cardiologist again. Their BP might be controlled, but as a side effect of the current medication, they are getting peripheral edema. So they should change, and they might need to go on a dose of diuretic also. Then after a week or so, you will see the pulses are much better. Then the foot is in a proper position. As a specialist in the foot, why you need to be aware about all this thing is, when a person starts their day, their foot is not as swollen as in the evening. So normally also our foot is comfortable in the morning because of non-weight bearing throughout the night. And as we start bearing the weight on it, by the end of the day, the foot is too tight. So when we are asking a patient to go and buy a shoe, we ask them to go and buy it in the evening, so that they can get a proper fitting shoes. Because once they buy in the morning, it might not fit them well in the evening, specifically the leather shoes. So they should be cautious that they buy their footwear in the evening hours rather than the morning hours. And for diabetic, again, if there is too much of a pressure in the foot, and the shoes are tight as term of physics, they can also have headaches, back pain, neck pain, just because of the compression of the foot. The nerves, I will cover something about it in the coming slide also, but for your reminder, that is clinically very important to see the swelling in the foot, even if you're seeing for normal individual without any foot complaint.
Okay. Thank you, ma'am.
Anyone else? So shall we move on, or take a small gap again? Break is needed. Anyone wants a break, or shall we continue with the next module? Dr. Saurabh? So I'll continue then. Now let's discuss what are the major conditions. I'm not covering all. the ones that you might be seeing in your clinic or might see if you are talking about this thing. So if you know this 4-5 condition very well and how to treat them, you can attract more clients to your clinic. Okay. So very first thing is, let's talk about plantar fasciitis. The right term to call it is plantar fascinopathy. Fasciitis is not the right term because we don't know whether it is an inflammation or not, but it is a pathology of the plantar fascia. The function of the plantar fascia is like a trampoline under our feet. Every time we are standing and walking, our foot collapses. We do the shock absorption with the help of plantar fascia. The bone collapses down and then it throws it up. So this constant action that is provided by the plantar fascia is very crucial for our day-to-day life, walking, standing, doing all the things. Now what happens is, if say this is our foot, okay, this is where the plantar fascia is starting. There is one end over here and then four end between all the digits is going. Okay. Now if somebody is having a tendency of flattening, so as a human we walk on an average 5,000 to 8,000 steps in a day without exercising. So that is our normal walking. To us, like in our lifetime, we walk this much that we can take 4 rounds around the earth surface. So that much walking we are doing with the help of these feet. Now what happens every time when you are walking, these bones collapse down. So there is a overstretching of the plantar fascia. Till the time it can take it, it keeps on taking even with the weight and everything. I would again say weight is not the only factor, but it is about the way you walk. Weight body can take. A simple thing is like when you go to a gym for the first time, lifting 5 kg of weight might be difficult, but if you go again and again, after few weeks you can lift double the weight, and then after a few months you can lift double your body weight also. So your body has a capability to load itself by increasing the muscular strength. What it cannot do is when you are loading in a wrong direction. So you take a dumbbell and you use your bicep strength and do it, it is possible. But then you take a very uneven, say a cylinder, it is difficult for you to lift it. Okay. So same weight dumbbell is easy to lift than a cylinder because of the biomechanics, the way you have to stand and put it, and the volume, it is a horizontal thing. So that is important. So same way in foot, what happens? The plantar fascia start getting a little worn out from here. So every time you're standing and walking. So this is where the heel pain is basically. Now what can increase this thing? The plantar fascia is going and supporting the arch also. Okay. So this is angulated. Now first compression came because of the fall of these things. So the fiber is overstretched. Now a overstretched fiber, because of the inward rolling of the foot, because of overpronation, is twisted. Now the ligaments and all are fibrous structure, so they can take a load for a limited period of time. If there is overpressure over there for a long period of time, the fibers start breaking up. Now when it reached to that point, when they start breaking up a little bit, it is called as plantar fascinopathy or plantar fasciitis in common term. The typical symptoms around that point, the patient will come to you and say that every time when I get up early in the morning and I put my foot on the ground, I have severe pain, and that pain reduces after walking a few steps. And then if I sit for too long and then again stand, then I get the pain. If I'm standing for too long, I feel tired, I cannot do so. So they start shifting their weight here and there. So these are the common thing that they will say when they are talking about the plantar fasciitis symptoms. Now what is the reason behind it? So when you are in a non-weight bearing position, why we ask people to have like 6 to 8 hours of sleep. Our body basically repair itself when we are in a sleeping position. So there's a lot of repair work which is going over the night. Any kind of injury that is happening because of 8 to 1,000 time of rotation cannot be healed in few hours time. So when they get up early in the morning, that area is poorly supplied by blood, and on top of it they are loading it. So that's why they feel the pain. If um, They got up, sit for some time, hang their feet by the ground, let the blood flow, do simple dorsiflexion, plantar flexion, inversion, eversion, and rotation clockwise, anti-clockwise. 10 times also. That will pull a lot of blood to the leg. And if they stand with that, it will not cause them a trouble. Now if they come to you and you start a treatment, uh, if I would like to be a little interactive here because that will help me in guiding you what to do, what not to do. So just if anybody can participate and tell me if a plantar fasciitis case come to you, what you do, what's your line of treatment? So Richard, would you like to say something about it? Have you seen any case with plantar fasciitis? You can unmute and answer.
Yes, I have seen that case in my clinic.
Okay.
Mm,
So what
when
was the presenting complaint?
the patient says pain on the arch, on their arch.
Okay.
So in our clinic, we mainly deal with the releasing of plantar fascia
Okay.
using the tool.
Okay. And how you release?
With the tool.
With the tool. Okay.
Yes.
So you use ISTM. What do you use?
That my MFR tool now.
Okay. And how does it help?
After releasing, we ask the patients to just walk and how you feel, and majority of the patients feel better after our releasing.
Okay. And how many sittings does it take to do so?
The very much if the patient come in the first meeting, we ask them to do the releasing.
Okay. And
Then
you see them back again after some time, whether
yeah,
the pain is gone?
we will consult him after 1 week.
Okay.
Along with that, we will go for the muscle strengthening for tibialis anterior.
Okay.
Then we will give that releasing with our tennis ball on the downward of the heel.
Okay.
Other techniques, dorsiflexion, plantar flexion movements, actively.
So what is a satisfactory result in this case? After how much time do you think the pain goes away?
After 2 or 3 consultation, the patient will be all right. We also release the calf of the patient,
Okay.
calf muscles. After all this, we will let him to do other some stretches or for the calf and hamstrings. After 2 or 3 consultation, within 3 weeks, the patient get all right, I think.
Okay. Someone else was willing to talk about it. Can you unmute and tell me?
Yes, ma'am.
Yeah.
After
Hello.
you, sir.
Hello.
Yes.
Can
Yes,
I
sir.
speak, ma'am?
Yes, sir.
Yeah. Yes, ma'am. I have seen plantar fasciitis. Main
Mhm.
focus on the myofascial release technique.
Okay.
It involves active release technique also,
Okay.
ART, even
Okay.
passive release technique, even
Okay.
instrument assisted release technique also.
Okay.
Some cases I have seen tibial nerve involvement.
Okay.
Patient complains of morning stiffness as soon as they get down from the bed.
Okay.
The first step would be very much
Painful.
painful and stiff.
Okay.
It was like apparently it was like plantar fasciitis, but what I assessed like it is a tibial nerve involvement. So we do
Okay.
tibial nerve flossing technique and all these things.
Okay.
It's like mimicking the plantar fasciitis, but it actually neuropathy or neurogenic pain.
True.
And true plantar fasciitis, as I told, releasing the plantar fascia
Okay.
and rolling like ice cube, putting ice in the bottle and rolling upon that releases.
Okay.
And in some cases, like I have seen cuff muscle hypertrophy.
Okay.
calf muscle are hyperactive,
Okay.
sometimes spasmodic also. In those cases, I use dry needling technique
Okay.
to reduce the hyperactivity,
Okay.
means inhibiting the calf muscles.
Okay.
Even
And
Achilles tendinitis, in some
yeah.
cases, I have seen Achilles tendinitis or
Yes.
tendinopathy. People
Yes.
who have less efficiency of the Achilles tendon or Achilles insertion pain, that also mimics plantar fasciitis.
True. So now,
Lastly, the
now,
stretching.
once your treatment is done, how you make sure that they will not land up in the similar kind of a pain? Like technically speaking, what would be the effect of myofascial release, uh, dry needling, taping? For how long do you think it will have a permanent effect on the body?
Yes, until unless we correct the biomechanical faults or biomechanical alignments we don't do, the problem may occur, may recur in future also. So biomechanical alignments is the main thing. Is there any fault or like that? That we have to access very
Okay.
thoroughly.
Okay.
Even flat-fitted,
Yeah. Will
I have
will
seen plantar fasciitis.
Yeah. So yeah. So I'll cover your points along with what Richard has said, and rest of you will talk on the next topic. So now, so this is the foot. This is the plantar fascia. Now this is the calcaneum. So calcaneum is not only supporting the plantar fascia but supporting the Achilles tendon also. Achilles tendon is attached on top and plantar fascia is on the bottom. So we have discussed the lower level causes of pain of plantar fasciitis because of the change in the structure around the foot and midfoot area. And then what are the external factor that can cause the problem on this thing? So if somebody is having a tight calf, the Achilles tendon attachment is sometimes inflamed, which is in terms of Achilles tendonitis. Along with that, it is taut. Okay, if somebody is having a bow leg kind of a deformity or a hyperextension, in that case also the calf is tight and the tendon is pulled behind and stretch up. So if there is a torsion force over here and here, then usually because of the weight bearing reason, there is a pain complaint around the heel of the foot or back of the heel. Now, in this case, after 2 to 3 months, if they try to conservatively manage this, plantar fascia is something which the pain dies on its own because of the compensation. Okay, same way like the stages of shoulder, there is a freezing shoulder to frozen shoulder. The freezing shoulder is painful, but the frozen shoulder is not that painful. It's only the movement restriction. So same way the plantar fascia, when it is active, there is a pain, but then it started compensating by malpositioning the joint, and later on there is no pain, but deformity. Secondary compensation of plantar fascia is heel spur. So in previous previous generation of physiotherapists or still the orthopedic and MBBS doctor, if they talk about heel spur, they say that आपकी हड्डी बढ़ गई है. There is a bone growth. Now technically it is not possible to grow your bone after a certain age. The bone is the same, only there is an extra osseous bone formation in the tendon of plantar fascia due to the overcompensation. Now these can be a little sharp and pointy and pokey. So the patient will not say the pain is all over the heel. In plantar fascia stage, they will say they will hold the whole hand and they say my heel pains. Then it is more on the bottom of it. Then after 2 months, if they are coming, they will say it is all over from here to here, it is paining. But when they reach to 2, 3 months down the line, when they reach to the spur age, they will point the finger and say that I get heel pain over here. When it is happening, it means it is a stage of spur. So without any X-ray, you can confirm that diagnosis. If you want, you can ask them to do the X-ray also. Now, if you are talking about calcaneum spur, calcaneum spurs are more pokey. But again, there is this thing like if I take a pen and I start poking my skin, so maybe the first 50 or 60 time I will feel the poke of the pain. Then what will happen? This area will become dry, lack of blood supply will be there, and it will be desensitized. So I will not feel the pain further when I am poking it. Okay, same compensation happen around the area of spur in the foot also. They make it tough, they make it a little calloused from inside. So when the spur touches that thing, it will not pain. Now in terms of doing the release and all those things, it do work, and sometimes the pain is completely gone, but mostly it is in the very first incident, because first time when the heel spur or the heel pain is happening, there might not be various compensation that you will see. So you will get lucky in the first time by releasing the tendon or using the instrument, the pain is gone and the patient is not complaining. But trust me, if the doctor trusts you, 2 years later, they will come with a lot of foot flattening, compensation, and more severe pain. And no matter how much you try the dye needling or the release and all those things, the pain will not go completely. They will still have residual 20-30% of the pain. The reason being the ankle start pronating a lot, and now this spur is touching different part. So when the foot is stable, okay, there is no compensation over here, only the foot has been overstretched. So sometime when you take a x-ray for some other reason, you see a big spur over there and the patient says, I never had any heel pain. The reason being the fascia was stretched, but there was no turning of the leg. So when the foot is not pronating or supinating, the spur is not touching any new part. So it is like the mortise kind of a thing. Ki wo, that sharp portion is touching the dead portion and you're not having the pain. But if they have a pronation supination issue, then it is touching new part every other week or day, and about 8,000 to 10,000 times. Every step they are taking on the foot, it is happening. So that is painful and little tough to release by traditional method. So then when we are talking about the posterior, we can get a Achilles tendonitis, bursitis, or a spur also. That is called as retrocalcaneum spur. The spur under the heel is calcaneum spur, and this is called as retrocalcaneum spur. Equally painful. What you can see is a little swelling around it. When you touch, it is palpable, and you will have pain and discomfort on touch. When it is a Haglund deformity, okay, it is called as pump bump or Haglund deformity. In pump bump or Haglund deformity, just when we wear the shoes, okay, the circle of the shoe comes at a particular point. If a person is in habit of using one kind of a shoes all the time, then there is rubbing of the skin over that area. So one thing is the skin thickened over that area, and the ligament also get more thicker. So you can see like a bump coming on that thing. And because it is happening due to the shoe, it is called as pump bump deformity. Some people are born with Haglund. Okay, Haglund is something where this is a prominent swelling on this area, hard to touch, may or may not pain you, but then if it is inflamed, this area is an area of weakness. So if there is an internal bursitis that is happening, it is hard to notice, and the pain is over the back of the heel a lot. Best form of treatment for that is to do cold pack. Rolling of cold pack, I don't know if there is any scientific evidence to say that if you take a ice bottle and you roll your feet on it, will work or not. It do gives you soothing effect for some time, but to solve the inflammation part, it is not sufficient. So as a doctor, if you are prescribing, then prescribe them to do cold pack, wrap around that heel area wherever is the pain. So it needs to be wrapped around for about 15 to 20 minutes. Okay, and explain them why. Okay, tell them about that what you want is you want to cause hypothermia at this point. Once there is hypothermia and the decrease in the temperature, the body gets numb, and as a compensatory response, the brain starts sending more blood to this area. Okay, in layman terms, try to explain them. When there is an increased blood flow, what it does, it not only take the so as a part of byproduct, you know that lactic acid comes in these joints due to constant action. So it flushes out all the pain causing and inflammatory causing chemicals from there, and the blood supply is regained. Now, when the new blood start coming to the area, it will also help in regenerating the tissues that are broken. So there will be faster healing. What we want is not to reduce the pain, we want it to be permanently gone and healed. So all that pressure, compression due to the different movement of this thing should be controlled for good, not for temporary. If we move on to the, so this is like hind foot, you will see these kind of a thing. Uh, yeah, almost these are the major problem for the hind foot that you can see on a regular basis. In the midfoot, usually there are pain and discomfort, but more of injury related, and the pain around the arch will be treated differently. Then comes the forefoot area. In the forefoot, there could be pressure wound, callus con ulcers that can happen, or the Morton's neuroma that happens. So squeeze test is a good test to determine whether there is a Morton neuroma or not. Why Morton neuroma is there is because of the fact of flattened transfer arch. So your forefoot loading increases. There should be like a percentage distribution between hindfoot, midfoot, and forefoot. Forefoot is good to load when you are into a walking cycle, but in a stationary position, if you are loading too much onto the forefoot, the nerves get compressed. Other thing that can cause Morton neuroma is when there is excessive overpronation, there is a lateral deviation of the foot. During the lateral deviation, the midfoot bones come close together and it can compress the nerve. Okay. So due to the nerve compression, there is distal pain. So every time they are walking, they are having forefoot pain. Don't get confused between metatarsalgia and Morton's neuroma. Morton's neuroma is a neural involvement where the nerve get thickened and that is causing pain distally. In metatarsalgia, the pain is over the aponeurosis, but it is more bony. So when you do like a bone test, when you're doing each and individual bone glides and all, you will feel the pain in that. So that is metatarsalgia. If on a squeeze, you're feeling the pain and it is sharp and it is pointed. Okay, they can point at certain area. So then it is basically the Morton's neuroma. Usually between the second and the third digit, if you touch between that area, you press it, you will see that they start getting pain. So this is the area. If you touch, keep one thumb on the bottom, other index finger on top, and try to pinch that area. They will feel the pain. Now for the treatment part, you need to support the transfers, this thing. Nothing else will work. It will take time for it to heal, and medicines and little release of the muscle above will be the solution for that. It's a very nasty problem, usually seen in females wearing stilettos or heels or tight fitting shoes in the front. Males who wear too flatter footwear or too tighter footwear or a size smaller footwear can develop this Morton's neuroma. So whatever advice for them is to wear a proper supporting shoes with a broad toe box and a good depth. So that can help in releasing the pressure on the Morton's neuroma, reducing the high of the heel. So what happens with stilettos and high heel thing also? First thing, the metatarsal pressure is increasing. Second thing, what happens if, say, for my profession, 8 to 9 hours I am in a heel, then my Achilles tendon is shortened for that much duration. So when I come home and I go bare feet or say a very flattish sleeper or something, home footwear, then there is a lag between the stretchability. So my Achilles tendon, which is shortened for the whole day, cannot stretch itself immediately when I get out of the heels. So ideally, this is the case where the release thing do work. So you need to release the calf for that and ask the person to do stretches in the calf stretches on a regular basis, like 2 to 3 times a day, not only when they are coming to the clinic. They have to do the calf stretch 2 to 3 times a day if they want to continue wearing the heels and all. Certain profession, they cannot do anything, they might need to do so. The only thing is that what you can ask them to, instead of going for a stilettos, which is more sharper and the heels are more narrower, you can go for a platform. So platforms will be having the height raise, but not squeezing of the plantar surface. So the footwear is little broader, so they can accommodate the foot better. Uh, Turf toe is basically inflammation around the first ray due to the capsule of that area getting inflamed. Usually, people who have a bunion and a tendency of running long distances and all those things, they get inflammation and pain around that area. Again, conservative treatment work very well, but if there is a repeated trauma, then it is difficult to manage it only by cold packs and stretching and exercises. Some or other kind of orthotic compensation is needed so as to offload the pressure for good around the great toe area. Shin splint is a very common issue that you see on a regular basis. The reason that could be are basically overexertion. So most of the people have a well-developed calf, specifically the people who are into gymming, running and all. Because of their constant running on the feet, their calf is well developed. So we know it for the fact there are agonist and antagonist muscle. If one is too strong and the opposing muscle is not that strong, obviously the weaker one will have a lot of pain. So people who are having tight calf, hyperextended knee, and a little rigid midfoot will complain of shin splint more. People with flattened foot might not have too much trouble onto the shin splint side. So basically, it's the high arch people which will have. So if you make insole and orthotic, which is giving a good contact at the midfoot level, the shin splint pain reduces, and then you can continue with your rehab and exercise program. Uh, Helix valgus or bunion. Okay. Now it's a tricky thing to treat even with the orthotics. There is a lot of compensation that happens due to helix valgus. There is a sharp turning inward of the first ray. As we discussed before, first ray is a very important component when it comes to our standing and walking, and that is the area which is now taking four times our body weight when we are into a walking cycle. So if the great toe is deviating inwards, it is a big disadvantage for us to stand, walk, run, and do any activity on the feet. Another thing is the structural part of it is cosmetically it is ugly looking, so people don't feel good about their feet and they try to cover it up with footwear. And once they try to do so, they in the end force the great toe to go more inward. Um, what so if it is like a congenital thing, then that angle is there, so it's not going to change very rapidly. But if it is due to a fallen arches, the more there is a navicular drop, the more the great toe will turn inward and there will be a deviation, and that deviation will force the first toe onto the second toe. It can even go and cross each other. When that happens, the space between here and the midfoot is reduced. Again, would be a great chance of having metatarsalgia, Morton's neuroma, ulcers under the feet happening because of that. Not only there, but the medial aspect of the great toe, around under the great toe area, you will see big, thick callus, which is yellowish and painful often. Sometimes there is a redness and swelling because of the shoe compressing it. So the whole area you will see a redness. Now for the differential diagnosis, you have to get the uric acid test done for determining the cause of toe pain, because that's a common site for gout also. So if somebody is complaining a lot of first ray pain, then you will do the physical examination, check the range of motion, check whether it is a helix limitus or rigidus, see the flexibility around the other joint. And if you don't find a good reason for them getting a pain over there, which is constant in everything, not only movement, then it could be because of gout. So for a differential diagnosis, get the uric acid level checked. A lot of lower leg pain are a result of vitamin D3 and B12's deficiency. So if they have like a constant foot pain, weakness, or difficulty in walking, they might be having a mild osteopenia or deficiency of vitamin D3. So it will be good if you're seeing a person with multiple joint pain and letharginess and all those things, get these two tests also done simultaneously. If their level is low, then ask them to take proper medication for that. Once they do so, the rehabilitation is much faster and the pain is gone in much shorter time duration. Uh, Other thing, like now we can talk about a little in terms of flat-footedness or flat feet. There is again no measurement that this flat foot is very severe or that is very severe. Even every other case when you see will feel okay, this is the maximum that I have seen, and now nobody else can come with such a worst flat foot. But in my life, in last 10 years, I was always surprised by the next patient who comes. So it is something that is very common and can happen to most of the people. When we are talking about broadly the foot problems, 80% of it is towards the pronation side, and only a few will have a supination kind of a issue that you will see. Another fact that you will see is the kids pronate at a age of 2 or 3, but at by 5 or so they start getting it to the normal. If there is no change, then it's a pathological and needs to be corrected. So while seeing the flat footedness of the foot, you will see the subtalar joint, see the mobility of the subtalar joint, see whether there is a windlass mechanism present or not. You will see the navicular, palpate the navicular, see whether you can get the arch back. What you can do is you can do a card test also. Take a visiting card and try to put it inside the foot on each side. So the side which is having higher pressure, say if you don't want to invest in a pressure plate and scanner and all those things, just take a card and try to put it on all the side, whether it is going easily or whether it is giving resistance. So if the pressure is high, you will not be able to put anything, even a small card also. You can ask the person to stand and ask them not to move or do anything. Just make them stand and raise each and every toe with your finger and then do it on the other side. Then you can compare whether they are loading more on one side than the other side. It's a comparative analysis that you can do. Then see the person standing on one feet, how they are standing, if they are being balancing well or not. If they are balancing, whether they are balancing towards inward or towards outward. So you will know the compensation while they are standing, if they are using the lateral structure more or the medial structure more. The connection is to the glutes and hip. Okay, when you are seeing the single leg this thing, you don't have to see about what is happening at the foot, you have to see what is happening at the hip and spine while they are trying to compensate for the foot. So you will know that if foot is not stable, they will have a lower back pain or a coccygeal pain or a sciatic pain or a gluteal area pain also. So if you treat the foot, you will see that those pain are going much faster. When you see a person from behind, you will see the calcaneum angle, which we have discussed in foot posture index also. So the more you are seeing the feet, you know the severity of it. That is how you will check it. Another thing that you check is when they are standing from behind is the knee fold, whether the knees are in alignment or not. So at the popliteal fossa, the knee lining, you just check whether they are in proper line or not. From the front, when they are standing, you will see the tracking of patella, whether it is medial or lateral, how they are standing, how the foot feels. So then you will know that if quadricep is weak, which component of quadricep is weak, which you need to focus on the strengthening. Most of the time what we see is VMO weakness. So in physiotherapy, we focus a lot on VMO, but there are sometimes a combination of IT band tightness with flat footedness. So you need to work on the IT band as well as strengthen the quadriceps, apart from releasing and all those things. Then about the hind foot. So hind foot, the importance of hind foot is it makes a kind of a junction box. Okay, from the plantar, the ligaments and all. When they are the nerves that are traveling from foot towards the spine, okay, they are first horizontal, then they turn upward and go upward, okay, in a vertical direction. So that happens, the junction point is called as pota pedis. Now, if my foot is turned in this severe way of pronation, then all the structure that has to cross from behind will also be getting a lot of compression. So if somebody is having, so this is where your clinical thinking should comes in, that if somebody is having so much of a overpronation, the whole structure is going medially, there is a lot of compression that is coming to the nerve. The nerve always want a clear and a resistance less pathway. Now imagine the kind of resistance these ligament and bones are putting onto each and everything that is crossing, not only the blood circulation but the neural pathway also. And that neural thing can give you dermatomal pain to different kind of associated pain at other joints also. What happens in the pes cavus? So as we discussed this in this picture, you can see clearly this is a high instep. Okay, if we see the previous picture, okay, see this previous picture of a flat-footed person. This instep, okay, this instep is not as high. You can see that. So here the instep is too high. You can clearly see the midfoot bones are too tight over there. Here is where we were talking about the fossa. So here the fossa is more prominent. See the compression that is happening at the first metatarsal joint. This is the, okay, this is the area. You can see the pointer or it's not visible. So this is the area where you will see the redness, swelling, and people who are high arch or tight foot, they will have this area more thicken also. So their transfer arch is at a higher position because of that higher position. So when the transfer arch is So when the transfer arch is at a higher position, then the pressure is coming directly onto the great toe area. So that is the area where you will feel a lot of pain and discomfort. Now, if we are talking about the injuries that can happen around the foot, two most common injury is the ankle sprain, whether it's an inversion or the eversion. Uh, what happens? Mostly for the kids who are into football and sports which are involving a lot of running on the ground and everything. Sometimes the foot, because foot has to do the locking and unlocking on a very fast pace. If somebody is having a compensated foot, say they are having a flat foot and they are into sports like football and something like that, so when they are playing on a turf or say normal ground also, and their foot is landing, it should ideally, there is a very small duration in which they should lock it for stability. Sometimes because of frequent changes in the movement, the foot is not sufficient enough to do the locking mechanism and they are unstable and then they twist their leg and fall. Apart from the direct injury, somebody came, banged, their foot was in one direction and they twist and turn around. That's a traumatic injury that we cannot control. But these kind of injury that happens due to altered biomechanism is something that if it is scanned at an earlier level, we can prevent a lot of injury in a sports individual. So that's why this diagnosis of foot, whether it is a properly distributed pressure or not, in the gait cycle, whether the things are working fine or not, it has to be done very precisely to see the locking and unlocking of the foot. And if it is not happening, ideally two things needs to be done. The shoe has to be more supportive for them, and secondly they should use some or other insole and orthotics, so that at the time when the locking is not happening naturally, at least the insole will give them support and they can avoid a lot of injuries and pain. Even in runners, there is a lot of improvement in their running duration and time, and they can run more efficiently if they are using an insole and orthotic. Now, these are the cases where we are talking about weight bearing. If we see a cyclist, there is a lot of study done for the biomechanics of the cyclist, and it is concluded that if a person is having overpronation and cycling, and they are using no insole compared to somebody who's using an insole and orthotics, there is a better performance from that, because when you have something under the feet, even the knee while cycling is controlled better. So that's why using insole for non-weight bearing process is also good. Now some person are into sports like swimming and all. Again, you cannot wear insoles in correction while you're swimming, but it is equally important for them also to have, like if they have a flat foot, to use insole and orthotic while they are training for the regular thing. So you do a lot of on-ground training. For that also they need to be careful to use that. And I have seen a national level swimmer. He has actually, after 6 months down the line, using the insole for his gym training and other exercises, his muscle and patellar tracking has improved to such extent that his time duration was cut. Okay, so he can cover a distance in a lesser time. So that kind of a result I have seen in my personal experience. So I can tell you that there is a lot to do with the foot than just a correction of a deformity. In the market, there are various shoes which are available as per the foot type. So one has to be very much aware what is their foot type and what kind of a shoe they will buy. Okay, if they are not putting an insole also, that is fine, but at least buy the shoes as per your foot type. So if we are talking about a supinated person who is going into over supination, again, always remember that we are not doing it for normal person. It is only for over supinated person. So they have a high arch, rigid midfoot. The tendency of ankle is to land on the high. So when you say do a footwear examination, check the foot from the bottom, you will see the shoe is more worn out on the lateral side as compared to the medial side. So all the supinator will have the shoe rubbed off from the outer side. Lot of pressure on the forefoot. You will see the whole sole is like worn out from here. And then if the internal of the shoe, you will see there will be a lot of worn out lining on the lateral aspect of the foot. Okay, so this is what you see in the supinator. Now, if they have to be using the shoes, it has to be cushioned from inside. Then, if possible, say whenever you take a shoes and you check the bottom of it, you will see for pronators, they make the shoes thicker on the inner side. For supinator, they raise it on the outer side. So that difference is easily visible if you hold the shoes in front of your eyes and check both the side of the shoes. So that way you know which shoes is pronator or which shoes is for supinator. Now supinators have more trouble in finding the shoes rather than the pronator, because 80% of the population is pronator. The shoe manufacturers are making more shoes for flat-footed people rather than for high arch people. Another difficulty what the supinator feel is because of the high instep. If they wear like a lace shoes or something and the lace is tight over here, they feel a lot of compression and pain around the instep area. So what they do is they go for a slip-on shoes. So elastic is not causing them a lot of compression. But in wearing a slip-on shoes, what happens when you buy them new, the elastic on the sides are good. But as they keep on using it, the elastic get worn out and the heel start turning outward more. So that is not supporting them. So in ideal case, whether you are a flat-footed or a supinated person, you should use more of a lace shoes rather than a slip-on shoes. And walking in a sandal or chappal should not be an option ever to your patient. So do ask them if they say that some geriatric patient is coming to you or something like that. You ask them how they walk, what they wear for walking. While coming to the clinic, they might not be wearing the shoes and you assume that they will not wear, but then it might be possible they are walking in their sandals or slippers only. So ask them what they wear and ask them to bring it to you if they say that they go out for a walk in the morning. Other things to ask is what is the pace. So you can ask how much distance you cover in how much time, how many rounds you take. So approximately you will know the pace of it. So if they are not wearing a shoe, the pace is gonna be low and the effectiveness of walk is not there. Again, when it is a diabetic person, you have to make them aware that they are supposed to wear shoes and socks every time they are stepping out of the house because of peripheral neuropathy and all. Their foot is not sensitive to touch and pain and all other things. So say if they are walking in an open footwear or a shoe without a socks and some sand particles comes in, under the feet, then they can develop a ulcer without knowing it. So for that reason, they have to be careful that they wear a clean pair of socks every time they leave the house. Always examine the shoe by their hand inside the shoes to see if there is any rough surfaces and something like that. So I have seen people coming with stapler pin inside the shoes. Sand is very common because we are in Mumbai, so it's a coastal city. People go out for a walk in the sand and all. Then I have seen a half nail inside the shoes. So when you are checking, you should check all those things because people take it for granted and they don't see it. Sometimes a small this thing stone and all is embedded in the shoes. So that also altered the position in terms of the way the foot is walking. In a neutral, the neutral shoes, both the side are equal. When you see them walking, the deviation towards medial and lateral side is not much. There is no compensation coming on the knee. So any regular shoes with equal length on both the sides they can use. For a flattened arch people, they need a control shoe. So what is a control shoe? If you take a shoe in your hand and you touch the back of it, it has to be firm and rigid. Okay, it should not bend easily when you are putting a pressure. When you hold a shoe in between and you try to twist and turn with all your pressure, the shoe should not turn. And in the front, it has to be flexible to do the rocking action. For flat-footed people or a high arch people, this kind of rocker bottom is also good, so that reduces the pressure on the forefoot area. So if they wear like a flat shoes, those are not very good for them. People who have sensitivity or hallux rigidus or limiters in the forefoot area, you should ask them to go for a rocker bottom shoes. So more the forefoot is elevated, the lesser the pressure they have. So tell them how to check the right kind of a shoes for them. If you are thinking of putting an insole, then it is important that the shoe should have a removable sole. So whenever you are taking the insole, you should take this out. So you take the insole. This is a flat insole. Now people say, "हमारे पास तो already memory foam वाला insole है. This will work. This will why we need an additional insole." So you can take this out, and very first thing you will show them the pressure mark, how their forefoot is having pressure. You will see the worn out pattern on the inside of the sole. You can show them that whatever arch, say this one was a flat design, but there are certain shoe which have like a arched insole also inside. So you can show them by taking it out. You put a finger and that sole drop down. When we discuss about the orthotic insole, that is never gonna happen. So pressure, everything, and then for practical purpose, you need more depth. Those shoes which are flattened, like if you say take a Converse shoes, they don't have much of a wall. The bottom is absolutely flat, and the material would be of canvas and all. So those shoes will not be very good to put an orthotic. What you need is ideally a sports shoes kind of a thing with all that three features that we discuss about, and a little depth inside for day-to-day walking and exercises. So any walking on running shoes is good. Now in running shoes, there are lightweight shoes which are more flexible. So if your purpose is for the person to wear the shoes all day long, you will ask them to go for a walking shoes, not the running shoes. In terms of branding, if you talk about Skechers as a shoes, what most of the people feel comfortable with because of the memory foam and the soft structure of it. Sometimes what happens if they have like a severe navicular drop and everything, the shoe is not sufficient enough to hold the navicular in place. So and they are mostly slip on what they choose. So when that happens, the shoe wall falls inward, and you can like if you keep the shoes down, you can see the shape in curving way on the medial side when they are using a shoe like that. So that particular kind of shoes you have to ask them not to use something that can help them to do. So shoe becomes like a part of your body when you're wearing it. It should not be an extra accessory on your body. Like how we wear the clothes and we feel comfortable, we should feel the comfort in the shoes also. It should not feel either heavy or too loose or too tight on the feet. More biomechanical issue that we can get is LLD, okay, leg length discrepancy. So during the gait examination, I have told you about what to see when you're seeing for LLD. Now, leg length discrepancy can be of two types, anatomical and functional. Anatomical are basically when somebody is born with certain deformities or a shortened bones and all. Polio cases, neurological cases, they all have those kind of a problem. If somebody has a fracture, injury, surgery, then also the bone is actually short, so there will be a shortening and easy to diagnose. What is and if you take an X-ray, you can see that the scanogram and all helps you to understand a anatomical shortening because of the X's and measurement criteria. You can measure it out that what and how much it is short. People after knee replacement have a lot of shortening, but you need to be very precise in choosing which leg is shortened. What happens in certain case, the side that we are so if they have a unilateral knee replacement, total knee replacement, while doing the knee reconstruction, the doctor do osteotomy also and make the foot as straighter because they might have knock knees and all those things. So they not only replace the knee joint, but they correct the angle also. Once the angle is corrected, in all possibility, this leg has to be longer. Okay, very few cases due to heavy body weight and early walking, when the cement and all is not as dry to hold it, they get a little compression of the knee. So that is the only way that the operated side can go a little shortened. In all cases, the unoperated side, because of the knee, knock knees and all those things, the knee is in a flexed position. So the uncorrected side is mostly which is shortened. But again, to compare it, you have to do the palpation, the whole gait evaluation, and a possible scanogram to determine which side is short. Now, in practical, if you are talking about, you see a lot of geriatric patients after total knee replacement, and still they are not standing, walking, and exercising. They come to you for rehabilitation. The idea is to make them walk on their own and increase their activity. Then the surgical point. Okay, if they were walking only half an hour before surgery, and even after getting the surgery done, they are walking half an hour, it's not an improvement, it's a limitation. So you have to tell them the idea of doing the knee replacement is not only to get rid of the pain, but to get better quality of life. And to improve the quality of life, they should do better and more things than they are doing before. So always motivate them to stand better, walk better, and do better. In functional leg length discrepancy, it is very difficult, as we say, to diagnose. So we do a lot of gait analysis, and then we do examination in a non-weight bearing position also. I hope you all know how to check the upslip and downslip by doing the maneuver, and check that also if the problem is at the hip. And then you have to do a differential diagnosis of the spine also. So if the spine is curving to one side, then it could cause this thing. But trust me, if you see a scoliosis, that is a functional scoliosis, the chances is that scoliosis has developed because of the foot, not the other way around. Spine don't have that much of strength and capability to make a person flat-footed, but a flat-footed person has the capability to make the spine go into scoliosis. Another thing is that if they are born with a small shortening, or there is a contracture or some injury due to fracture and all, they have a shortened leg that can cause a secondary scoliosis. So again, history taking is important to know what came first. Okay, would they have like in younger age also they were flat footed, or pain or injury or any accident that has happened at a younger age? What was the area of injury? If the area of injury was the foot, then it is quite possible that the scoliosis is from the foot, not the other way around. Another thing that happens because of poor foot alignment is the anterior and the posterior pelvic tilt. So if you keep on working on the core muscle, you want to get the ideal good posture, and you keep on working on the neck, you keep on working on the core muscle, back strengthening, abdominal strengthening, all kind of stretching, foam rolling, everything, and you have not corrected the foot, so your result will always be compromised. It might be compromised by 50% or 20% or 10%, but I can guarantee you that it will be compromised if you have not corrected the foot. If a foot is overpronated, internally rotated tibia, there is bound to happen. The foot cannot, the lower body cannot segregate itself. So it has to work together. So there will be a lot of anterior pelvic tilt that is happening in some or other form, and you will think like, okay, this person is obese, so that's why this anterior pelvic tilt is happening. So you keep on working to reduce the weight and everything. But what is need to be done is, when you are in anterior pelvic tilt and all, there is an increased forefoot pressure, and the person cannot walk for longer, stand for longer, or do activities with ease. There is a high pressure on the anterior aspect of the knee also, because of the anterior pelvic tilt. The best and the easiest way of correcting the anterior pelvic tilt is through insoles and orthotics. If you raise the medial arch, automatically the spine has to turn back into position. And then if you do the strengthening and walking and everything, it is with ease. Though insoles and orthotic are painful to begin with, rather than other activity, but the long-term effects are very good onto the patients. Then if we are talking about the knee as such, so what happens to the knee? If say my foot is flat, if knee is a hinged joint, both are sitting on top of each other. If I have an internal rotation of tibia, then there is a compensation of knee space on one side. There is opening on the other side and compression on the other side. So when I'm young, say I'm having a flat foot since childhood, I was having no pain complaint ever in the foot. In my college days, I was doing running, I was very active, I used to play all the sport. But now I have a pain, I can't do much, I can't run beyond 5 kilometers or 10 kilometers. And these kind of complaints are there with the patient. And they say that while going up the stair, I get the knee pain and all. That means a lot is happening in terms of torsion at the knee. Now at middle age, you cannot develop a knee arthritis or something like that so easily. So what happens when this person or me, I'm younger, I can use my cartilage and all for shock absorption, but over the years the cartilage start thinning out, and now my bones are locking each other. Then due to increased overpronation at the ankle, I have an internal rotation, the knee is coming, the socket is not sitting at a right place, and the knee is coming into a knock knee or a bow-legged position with a hyperextension maybe. So in all those things, whatever the structure that is causing the knee is compromised, the IT band will be tight, the posterior structure behind the patella, because the patella is not tracking well, then there will be chondromalacia patella and all that is happening. That's why I have pain in increased activity. And there might not be any complaint on the foot. Remember, people who are born with flat foot will never tell you that they have a problem. And when you tell them also, they will not believe that the problem is at the foot. Because of the flexibility, they don't feel it. So what happens? They will only feel pain when they increase their activity. Say for many years they were not running, jogging or doing anything, and they suddenly start doing it, and they come to you with a major complaint of knee, but might be mild complaint of the foot pain. So changing the footwear or maybe an insole would be a good choice at this age. If you don't do any intervention right now, thinking कि biomechanical correction important नहीं है, we work on the strength, and people have this mindset up that why I need to correct my flat foot when it is not giving me pain. Even in podiatry and other science, there is a big debate. If nothing is wrong, never try to correct it. That's a saying. So if there is no pain in the foot, why to correct it? But there are two school of thought for that. A simple explanation that I can tell you is example of a car. Our feet are basically our tire. The way we are standing and walking is only possible because of the foot. Same way a car has a tire. When we walk a smooth ride, what we need is a good air pressure in the tire. So if you have to go out and take a long drive, first you get the two thing check: pressure in the car and a car tire alignment. Okay, same way, if we want to do long distance running and heavy physical activity, you want to lose weight, we have good fitness goals and all those things, we have to first check whether the pressure on the foot is same or not. Okay, so we check that. If we are having a flat foot, it is like having a flat tire. And you these days, you know that we have a car with a tubeless tire, so it can still go on for a long duration of time without filling it again. But we know that there is going to be internal damage in the tire, and there is a reduction in your car average. The ride will not be smooth. So same way, if your foot is flattened, you will not have a long distance. Your energy expenditure is much higher when you are running on a flat-footed structure without much of a support. Okay. Another thing that is need to be is the alignment. So alignment is not only between one foot to another, it is about the feet itself. So hind foot to mid foot to forefoot, there has to be a structural alignment. If one segment is not in the right place also, you will get the trouble. So same way, everything is burning up the hinge joint of the knee. The pressure is coming from top because of the body, the anterior pelvic tilt. From bottom, it's the ankle which is overpronated, which is causing the tibia to rotate in compensation. Otherwise, the joint will fall apart. So the knee is never a culprit of causing you the discomfort. The culprit are either the top or the bottom. So you have to see what is more problematic. If the spinal alignment, obesity, and all those factors are more responsible for knee pain, then you go for management of that. And if you see the lower half is the one which is distorted, flattened, having a lot of con callus and this thing, then it can show the pressure points of the body also. So always look at the bottom of the foot and see whether the skin is harder in the front or back and how it is behaving. So that will help you in focusing which area to focus when you are trying for the correction. Now we'll take a 5-minute break, and if there is any question, I would like to answer now, and then we'll move to the next module. So we'll discuss the theories behind the designing of the insole. Then I'll tell you about different type of insoles that can be used, and I will try and demonstrate you the prefabricated insole, because that is the easiest thing possible in this scenario. So I'll tell you about the prefabricated insoles. Any question? Dr. Saurabh, you're here, or should we announce the break time?
Yes, madam. For 5-minute break.
So So we resume at 12:40 now.
Okay, I'm 10 minutes break. 12:40. Thank you.
কোনো নাম লিখা দেবো নাকি ডাইরেক্ট যাবো? হ্যাঁ?
So everyone is back now?
Request to all participants to join as soon as possible. And one more minute, madam, please.
Yeah.
Thank you. Yeah, please, ma'am, please start, madam. Thank you.
So any doubts that has came in last 10 minutes in your mind before we move on to the other aspect? Is everybody on board with what we are doing, or is there any other line of thought that you have? Would like to hear that we are going in the right pathway. Are you on board with things so far we have discussed?
Please unmute and ask if anybody have doubt.
Hello, ma'am. I wanted
Yeah.
to ask in cases of in cases where a child or an adult, when he or she runs, they
Mhm.
feel pain in their malleolus. Either it is medial malleolus or lateral malleolus. It's not severe. It only happens when they are running. So it is. It could be due to of patellar malalignment, or as you uh, as you said that it could be due to of any biomechanical issue in the hip joint or knee joint. But if it's specifically related to ankle joint only, so is there any particular uh, technique, or you can just let us know how can we biomechanically make the ankle aligned, like
Yeah.
what is the, like, either one or two exercises, or I mean, we know all the basic exercises, rehabilitation thing, but I
Yeah.
just want to know if there's some technique by which we can biomechanically align the ankle
Yeah.
joint in
Yeah.
its normal position.
So say in terms of exercise, uh, the funda is very clear. Okay,
Yeah.
you know the basic function. Okay, what are the joint range of motion? The ankle can only move in a certain way. It can go
Mm-hmm.
into dorsiflexion, plantar flexion, abduction, adduction, inversion, eversion. That is all.
Yes,
Okay.
sir.
So the concept of exercises come in terms of resisting those movement to develop more strength. You can use any innovation. You can use tandem walking to walking on a bar or a small surface. Um, but when it is about the alignment part, okay, what is weighing? So you have to weigh your option. Injury causing pain and a little deviation in the deformity can be treated with exercise and other intervention. Alignment is something where whether it is wrong from the beginning, now that kind of a thing cannot be corrected only by exercise. So your exercises are enough. The only reason that it is not working to strengthen a person is because of the alignment that is wrong all through the. So when say somebody is coming to you, they will only come to you as a physiotherapist till they are in pain. So all those things like how Richard said, that we do instrument assisted releases, muscle release techniques he used. Then Dr. Subradeep said that he used dry needling also alongside to release the muscle and everything. So all this thing will work. The only problem is once the pain is managed, they will go on living their normal life without any maintenance exercises. Okay, so one thing is that you have to make exercising for that particular areas, whether it is hip, knee, ankle. You ask them to do at least two exercises for them as a maintenance course if they don't want to come back to you for further treatment. So make them realize that part. So that is more important. If they go about and doing the same thing again, like wearing the wrong shoes, wrong type of shoes, wrong way of walking, exposing themselves to activity beyond their capabilities, those all will cause more injury and pain. So your exercises will fail because of that fact. Another thing that you have to tell them that after 3 months they have to come for a follow-up whether they have a pain or not, because once we start with a set of exercises, the effect of it would last only 6 to 8 weeks. So ideally this exercises has to change if they are doing it on their own regularly also after 2 to 3 months of time. You have to give them more complex exercises. So in terms of exercise rehabilitation, you first focus onto the area that is more affected bilaterally. Okay, always remember in case of foot, you have to have a strengthening bilateral, not on the weaker side or the painful side. Because when there is a pain, you will start putting weight onto the good side. And then the later secondary pain and all will be more on the better side, which is not having any even alignment issues also. So that would be the first focus. Then what you do is you start giving simple exercises to begin with them. A lot of time you will see issue with the balance and posture. So few exercises for correcting the balance and posture is a must when you begin any rehabilitation and exercise part. Simple same exercises that you are doing, but you have to make them understand why it is important. Each and every step you have to talk to the patient, you have to educate them like the way I am trying to educate you today. Same way you try to educate your patient, at least give them half an hour to explain what you are planning, what you're doing, and what would be the effects and side effects of it if they don't do it. Then the third step comes to a change in the habit and lifestyle. That is the most important thing. You can tell them that they have a forward neck posture, so whenever they are standing they should be, when they are working on a computer or something, they should have a proper posture and everything, but those things will not change on itself. So you have to have a strategy and plan to make sure that they sit properly, they have their posture integrated. So you have to make certain things that is comfortable for them. Say for a working individual, you can ask them for a reminder. Every 2 hours, there has to be a reminder for them to stand and walk and do little calf stretch, quadriceps stretch, whatever is possible inside a office environment without attracting the attraction from other people. So that could be like a strategy, and specific exercises and a specific correction method that works, I will tell you. But trust me, there is not much of a difference in exercises per se. The thing is just the approach. If you change the approach, the same exercise will work. So I will explain in the last module that how the insole and orthotic works and how this problem can be solved for good.
Okay, thank you so much.
Anything else, Mr. Subradeep? Yeah, doctor.
Yes, ma'am. Hello. Could you-
Yes, sir. Yes, sir.
Yeah, if somebody is having flat feet and overproduction, along with that, the patient has Achilles tendinopathy, okay, Achilles tendinitis. So which one
Yeah.
should be treated first, the Achilles tendinitis or the flat?
So your voice is breaking a bit. If you can type your message and send it in the
Yeah,
inbox, I will address in some time. You just type the message and do it, and in the clinical
Hello.
discussion
Now,
later on. Yes, sir. It's better now.
yes, now you can hear me. Hello,
Yeah,
ma'am.
I
yeah,
can
clear,
hear
sir.
you. Yeah.
Yeah, ma'am. My question is, if somebody is having Achilles tendinitis with that flat feet, so which one should be treated
Excuse me.
first?
Excuse me,
So,
Overproduction
sir.
syndrome.
I guess your
Achilles-
question is if somebody is having overpronation flat foot along with Achilles tendinitis, what to treat?
Yeah, which one should be treated first, and what is
All
like?
three together, sir.
Okay,
Okay,
okay.
so if they are coming to you with an Achilles tendinitis, that pain is so severe to stand and walk that if you don't do anything about it, they will be irritated with you. So you will address the Achilles tendinitis. You can do the regular technique that you use to do it. My suggestion for a quick relief is to add bilateral heel raise in Achilles tendinitis. So what you do is you force the Achilles in a shortened position. So that is the quickest way to give relief to the Achilles tendon. So if you see any case of Achilles tendinitis and you ask them to raise the heel, their pain is immediately gone in a day or 2 day time, or sometime instantly while they are even in their clinic. Second thing is there are Achilles tendon straps that can be given. So the funda of the Achilles tendon strap is there is a band with a poron material over here that compresses the attachment of the Achilles, and then there is the strap that goes down and you go and cross it onto the other side. So what you do is you basically shorten the Achilles tendon. So once you compress and lift it up, the Achilles tendinitis pain is gone, and then you can do whatever therapy you're doing. For my aspect, I would believe in doing a lot of cold pack every 2 hours, 3 hours for 2 days, and then after 48 hours, I see a considerable reduction in Achilles tendon pain. So if you have a Achilles tendinitis patient visiting your clinic, they will say that weekends पे pain नहीं होता, weekdays में ज़्यादा होता because of them. A little different than that for them, as they are not wearing shoes or something on a weekend and they are walking bare feet and all, they will complain of more pain in the weekend as compared to the weekdays when they are in a shoes. So they will always complain that walking bare feet is more painful. So as soon as the Achilles stretches, the pain is there. So in that case, if the symptoms or the complaint is like that, the treatment is that. That's why you need to listen to your patient. The more you poke them while you're taking the history, you will know the kind of pain that they have, and then accordingly the change in the lifestyle you can suggest. So that's the key thing that you can practice.
But ma'am, one doubt. Hello.
Yeah.
Yes, ma'am. Like bilateral heel raise, that is completely contraction of the calf muscles. Is
Yeah.
that not hampering
No, so
SI?
it's gonna be a temporary way of treating it because the pain is so severe they are restricted. So if you do a calf release and remember, if you see Achilles tendinitis, chances are the patient might be a supinator with a excessive loading onto the outer surface. Okay, that is how it's gonna be. So you can correct the supination and then also the Achilles tendon pain is corrected, or you give a temporary 1 week, 2 week of bilateral heel raise, a little cushioned heel raise, and the pain reduces. By that time, you will be doing calf release. Then you will go on to calf strengthening protocol. Okay. Then you will do extensive calf drop exercise. So when you do calf drop exercise, the range of motion is improved on both the aspect. So for the calf drop, you take a platform and you stand with your toes on it, and it has to go down also and then come up. So when you do that, say about, ask them to do say a set of 30 to begin with, then 30, 30, 2 set, and then 30, 30, 3 set, and then you can go 40 into 3 set. So when you do this in an extensive thing, then the range of motion is improved both ways. The Achilles tendon is elongated, and then they can go on. And you can see the difference in them. You are doing your release technique along with. So some improvement you can see before and after. You can make a video of them doing the exercises before, and after your release, you can see how much they can go down. If you see there is an improvement, then you continue with the exercise and do the release after 2 weeks, 3 weeks, if you don't see any change from your first session of release. So if you do too much of a release on a regular basis, you will also cause hypomobility also. So remember that it has to be a balance between both the things. You want the calf to strengthen more rather than be flexible. And another aspect is if they are into regular exercises, their calf is tend to be very firm and rigid. So a simple massage gun can also help them. So if you ask them to do foam rollers on their own, and if possible, you use a percussion or a massage gun on their calf muscle, you will see a lot of relaxation. But the whole area will be inflamed for about 2 to 3 weeks. Any inflammation when happens won't go back very instantly. So cold pack will take care of the swelling, internal swelling that is happening in the bursa, because tendinitis is always associated with bursitis also. And then you can see a better result. And once the pain is gone, you can remove that bilateral heel raise. It's okay?
Okay, ma'am. Yes.
Okay. So now we
Understood.
move on. Yeah. So now the insole and orthotics have changed over the year. The method of making it has changed over the year, but there are a lot of theories which are still getting scrutinized day after another for getting the best outcome and result, whether to use insole or not, how to use insole, how long it has to be used, should all the cases of foot and ankle pain need an insole. So a lot of debate keeps on going. The chiropractors say that if it is an alignment issue, corrected with chiropractic technique. The physios say that strengthening is the best part. If you strengthen, everything will be in place. The podiatrists will say that what cannot be strengthened or aligned should be aligned by orthotics. So everyone you talk to, they will have a different perspective about it. Nobody is wrong or right. It is about the patient. We have to think on that line of a thing. Say if somebody is too busy in their day-to-day lifestyle and activity, and you know that they can only afford 5-10 sessions with you for exercises and all, and if you are not there with them, they are not going to exercise. You make sure that you have given them something that lasts them for longer. If not, then they will have the same problem and again, and it's possible to have more grave danger to other joint, and they will lose the trust on you to come back again, because they will think कि when a common saying in India is जब तक physio के पास जाओ तब तक pain नहीं होता, and when I come back वो pain वापस चला आता है. So if that is happening, it is only for the fact is while you are exercising and doing the release and all those things, the muscle and joint are in a better position, and then again it goes into tightening and then pulling and all those things. So it's not your fault. That patient has to understand that they have to do the exercises. If we talk about the treatment of foot and ankle, there are conservative and surgical method force. If we are talking about the conservative method, dry needling, insoles, orthotic bracing, local injection, PRP therapy, anti-inflammatory medicines, taping, splinting, exercising, muscular release, all are helpful. Okay, so everything has its own importance and everything needs to be tried and tested. Before going for any surgical intervention, all the option has to be tried and tested for such patient. When we are talking about insole, there are ample variety of things available in the market. Insoles are basically two types. One is off the shelf, one is prescription orthotics or custom mode orthotics. It can be of full length or it can be of 3/4 length. It can be only a heel cushion also. But the more precise one are the custom made insoles. So I will let you know about the custom also. So people have a lot of confusion what is a insole. So very first thing I would like to explain to you, there is a difference between a insole and an insert. Say somebody is having a fat pad reduction due to long standing walking or in general poor health, poor blood supply, old age, so there is a fat pad reduction. If there is a fat pad reduction and this person is not having any alignment issues, then something which is of soft cushion, silicone kind of material can work for them. But if they have like a biomechanical issue associated with that, see these are like insert, they are flat. It could be full, it could be only heel, it can be a heel cup, but those are all temporary relief. So you know that you have a fracture when it is an alignment issue and you're using a band-aid to solve it or a crepe bandage to solve it. So it may work for temporary 1 or 2 hour, but then when you start weight bearing and loading, these kind of a thing for a flat-footed person will not work. This is only a cushion and a shock absorber, so it can only benefit that much. So if there is a normal arch person wearing wrong footwear, so kabhi unhone they bought a new pair of a shoe and they started wearing it all day and they have a soreness and a pain, so that can help them. And these are both mostly off the shelf. You go and buy it as per your size, cut and trim, small, medium, large, these kind of a size that they are available. Then there are off the shelf insoles. These are insert. When you are talking about the silicone stuff, they are called as inserts, and these are off the shelf insole. So they come with a basic designing. Okay, they have a arch support. They have a top cover, a cushion top cover, a little raised arch. Okay, these are not flat, so the arch helps in controlling a heel cup to help in supporting and a flexibility in this. So if somebody is having a normal alignment or a high arch and they have little discomfort, not like a regular pain, for temporarily 2 months, 3 months, 6 months, though the life of good quality is a year or more, you can give something like this. Okay. So for certain cases we use this, but most of the cases they come to us with more defined like deformity and severe pain and discomfort. So we go for the custom ones. Um, Now, the debate whether the foot orthoses are of any use or not. People who use it, they find it very satisfactory. They find good result. Their pain reduces. They can see the changes in their walking pattern. They can stand longer, walk longer. They feel like being active. So these are the effects that the patient will tell you. Uh, if we see about the sciences, they again everybody will have their own this thing. So there are a big chunk of people who are believing into barefoot running and barefoot walking, staying close to the nature, having the natural alignment is the best possible this thing. Nothing is wrong, but living in a urban culture or a city, you have to wear a shoes to go to office. It has to be something that can go with your profession and everything, so you are bounded to go. So it's not by choice, it is that you have to be in the shoes, so you cannot choose to go to work and this thing. So it will not help you if you're just doing bare feet walking and running in the morning and all day long you're wearing the shoes. If you go bare feet, it should be 24/7 so that your body can adopt to it. All the muscles, joint and everything are ready to do so. So there are few theories on based of which the insole and orthotics are made. Okay, 5 of which I will tell you in brief, because still you are not too much onto the podiatry side, so something you can understand. The very first thing that came in 71, 78 is the root theory, which was very much accepted by all the podiatrists all over the world. Root came with a theory that for an ideal foot, the subtalar has to be in a neutral position. So he was totally focusing on a subtalar neutral alignment. If you see a person, when we are talking about the foot posture index also, we were seeing the subtalar position, we were palpating it, and we are seeing whether it is medially or laterally. So everything has to be based, because that the ankle mortise is the most important part of the foot. Here is the plantar flexion, dorsiflexion, which is happening, and the rotation of the foot is happening. Shock absorption is also dependent on that part. So if the subtalar is locked in a uneven position, then obviously all the other joint congruent to it is having a trouble. So he came with a theory that make such an insole or orthotic to the level and height, whether it is custom or prefabricated, till the subtalar is reached to a neutral position. If it is not in a neutral position, your foot is compensated and it will give you trouble and all the point. So for a very long time, this theory was well accepted by everyone, and there were 8 criteria. Okay, the 8 criteria, what it says, like if you see your feet from behind, ideally it should be divided into 1:3. So if we see this is the medial component, then middle, medial, middle, and lateral, 3 parts of the foot. So the ratio has to be, if we draw a line in front of the ankle, it has to cross the foot in 1:3 ratio. If it is crossing it, it's a subtalar neutral position. Then the axis has to be neutral position. When you palpate and both the side, you should feel it uh, similar. When you see the leg from behind, if the subtalar is neutral, the line will be bisect in the center of the line will be vertical to the calcaneus. Then the metatarsal joint is in maximum pronation position. Then MTP joint has to be perpendicular and posterior to the calcaneus, जो हमने foot posture index में देखा था. And the foot is rotated outward on an average of 7 to 10 degrees. So when we are looking the feet at this way, so it has to be rotated outward. If there is a pronation, it is rotated inward. In this thing, it is ideally should be rotated outward by 7 to 10 degrees. Then the other criteria is dorsiflexion movement is maximum 10 degree. Okay, so that has to be maintained. If that is there, then it's the ideal insole and orthotic. He is not talking about examination, he is now talking about the correction. So while fitting the insole and orthotic, whatever method you should make, ideally what he said was these criteria has to be maintained to make the subtalar joint in neutral. Now, most of the insoles that are available, which are called as prefabricated insole, till date are made on that principle only. And in most of the cases, 70 to 80% of the cases, it does work. Though the theory is negated by podiatrists, but still the insole and orthotics made on these theories still work very well for the patient. After a lot of debate on Root's theory, a lot of studies were done by other scientists, and they find the loopholes in all this thing. So the next theory that was proposed was tissue stress theory. Okay, so there's a podiatrist, Kevin Kirby. If you like anything in podiatry, do follow him. He's a very good a podiatrist who give a lot of seminars and knowledge and all those things on foot and podiatry, how it goes. So he said that he and there were some other scientists also who have done this research. One of the prominent was McCoy, and McCoy and Fuller was the one who has actually done the experiment to prove that subtalar neutral is not the only criteria that should be taken in mind while making an insole. The tissue or the pressure point. So so earlier when the podiatry was developing, we were not having the pressure plates, sophisticated software to see how and where we are putting the pressure, whether it is equal on both the side or not. So we were making the diagnosis based on what we see on the skin, how they are feeling, how we are touching and feeling, all those things. So the touch and feel thing cannot tell you more about the internal thing that is happening. So with the advancement, when these pressure plates and all have come, they have find out that the malalignment at the foot and ankle has a lot of implication on the tissues that are there around the structure and even the area distant to it. So then when we are making an insole and orthotics, our aim has to offload the pressure from those soft tissues and structure and make them more comfortable. In early ages, the insole and orthotic used to be very tough and rigid. So when McCoy came, he said that keep the arch higher till the level you see the forefoot pressure is offloaded. So the insole that is made in Wesley with McCoy has that portion as an up and harder till heel to midfoot area, and the forefoot area is more cushioned and made up of forearm level, so that to get maximum relief at the forefoot area. We want the first ray to have maximum function. We don't want to restrict the first ray. We will only restrict the Achilles part of it. Then, just a second. Then in 1995, McCoy and Hunt together proposed 4 protocol in assessing the tissue stress. So first, identify the anatomical area where the pain is. Then apply the stress on previously identified area. Stress in terms of, say, if you say the pain is at the navicular area, you see the stress level and all those things, whether the pain increases or not. So you do that. Based on that assessment, you see any pathological or mechanical issue that are there and address those. Then you go for something that is more into reducing the stress rather than correcting. Say in the subtalar neutral theory, to get the subtalar neutral, I would put an insole and arch over here, which is too hard and rigid as per the body weight, so that the subtalar is in neutral and everything, I suppose, that will get normal. But in case if there is a problem in the navicular area, this navicular is at this point inflamed, then what I will do is I will still raise the medial arch, but I will give a little cushioning or a shock absorber material over here, so that the navicular is not irritated by the arch correction. So I want the correction, but I will not ignore navicular in the process of making the insole. So that is the crux of tissue stress theory. Then it comes to neuromechanical theory. Now, Binonig is the podiatrist who has proposed this theory after studying a lot of biomechanics. So he focused on both the option, how is the movement is controlled, what is the strategy of the body to control the movement, and how is the shock absorption is having. So as I told you that when a person comes to you with the initial heel pain or this thing, and either they don't seek any attention when they are having minor pain and all, unless and until it is manageable, they try to treat it by themselves by compensating the way they are walking, changing the footwear or changing their alignment. So if you can study the pattern, what is causing the change in alignment, and how they are doing the shock absorption part, how they are compensating for those things, you can understand what is the root cause, what is the impact and the forces that are there. And when you're designing the insole, it has to do correction in a way that it is not only structurally managed, but functionally also it is managed. So these kind of insoles are working more on the neural system, neural pathways, the way I want to give you proprioception. So proprioception is the key in these kind of alignment. So based on that, certain orthotics are designed. Implication is the cause of trauma is more about the muscular tuning. So here these are something which are more acceptable format of insole and orthotic from the physio community in foreign country, because of focus on muscle and joint both, along with alignment and insole and orthotic. The insole and orthotics are trying to work on the central nervous system itself. So there is a better correction. The gait and pattern is more focused rather than just the alignment which is there. Then Howard Dannenberg, I have used his insole, and he's again a very good scientist in terms of changing the whole setup and of insole and orthotic. And he has influenced the shoe designer to change the kind of shoes they are manufacturing. So he is called as father of first ray. He has done the maximum research on the first ray, its function, its mobility, helix limiters, rigidus, locking of the foot, and all those things. So in the clinical examination, when we see the foot and we see this is down and this is up, in limiters, we can get it back into the position by putting a metatarsal raise. If you put something softer under the insole, it can raise all the transfer arch bone up and reduce the pressure on the first ray. If it is a rigidus, this is gonna be down only. So what he suggested, instead of changing the insole, this is not, the plane is not matched. If the plane is not matching, there is always gonna be pain over here. So what he suggested is make a hole or a place where we can put there is a gap, so the deformity is accommodated, not trying to treat it but to accommodate it so that the pressure on the other is equal. So the insole that he made has like a the insole that is made on his principle has like a open area over here. So insole is same, but there has a foam or poron under here. Then you see whether the rigidus is from distal side or the proximal side. What is not moving? When you're moving the joint, what is not moving? What is not gliding as compared to other bone? Then what you can do is you can remove that portion of the insole by removing the pluck from the insole, and then you can see a better functioning. The pain reduces and the arch pain reduces, the heel pain reduces due to that. Same principle has been accommodated in a lot of shoes where uh, under the first ray area they give like a gap or a hole to do better shock absorption. So same principle has been adopted by various diabetic shoe manufacturer in this thing. For limiters, he say that it's a temporary issue, so you do the manipulation mobilization. As soon as you work on releasing the calf and everything, the helix is free. Helix is getting tightened up not only from local but also from the calf area. Now, the last theory, that is a combination of each and every thing, is the domino effect. Now, what is a domino? Dominoes are pieces of block. How the dominoes work? If one domino fall onto the other domino, which might be like 1.5 time to it, and it touches the block, it goes and it falls and it touches the block. The whole domino can go for kilometers to drop each and every block in the way. Same way, if our foot is our base of support, okay, on that we are standing and walking. And if the foot is internally rotated, which is causing internal rotation of the tibia, leading to knock knees, then rotation at the hip, and then the forward pelvic tilt that we discussed before, it's a domino effect. So if we want to treat the spine, we have to treat the foot. If we don't, we will not get this thing. So this is something that I would keep on stressing throughout, and that is the most and important key rule that you have to see. In physiotherapy, we check one or two joint. Say if the problem is there, we say that check the proximal and the distal joint, but always go down till the foot. Even for neck pain, there was a podiatric conference and there was a podiatrist who was giving a paper presentation. He said that one patient was visiting our clinic for different thing. Apart from all other clinical problem, he said that doctor asked like, are you on any medication or something? He said that yeah, I'm on some painkiller for my tooth pain. So for a very long time, he was getting the treatment done, but it was not benefiting. The patient came to the podiatrist for the flat-footedness. He did the insole and correction, and after 1 week, the patient said that my pain in the teeth has gone. So like my mouth don't hurt. So we know that the temporomandibular joint misalignment can happen. But it has the effect from the foot towards face. Nobody think on that line, but the domino is like that. It can affect you to that extent. I have personally seen a patient who was complaining that by the end of the day, I have severe headache. I don't like doing anything. What we did is we examined. He has an extra wide foot. In India, those kind of wide fitting shoes are not available. So he's wearing a regular leather shoe, which is getting stretched all over. So we asked the patient that for a week, don't wear shoes to the work if possible. So he was a big businessman and all those things. He said, it's my office, I can wear anything. So for a week, he started wearing sandals, which were open and little broader in that sense. And after 1 week, when he came for a follow-up, he was saying that I never had a single day of headache during that period. Because of the tight fitting shoes, even the headache was there, the migraine are there. So a lot of things which we don't see the correlation are related. And if we want to solve one problem, we have to see the other angle also. While doing all those things, while making the insole and orthotics and all those things, the principle of exercise, physiotherapy and all doesn't change. You have to do the same thing. You're just adding something, not trying to replace something. So your therapy will always be like that. So based on these things, what are now adopted as a designing component for most of the insole, and specifically the one that I use, is a combination of recommendation from Kirby and Fuller on the tissue stress thing. So what they recommend is use an insole with a deep heel cup so that the calcaneum can be in a good position. A well-fitted orthotic with a medial arch. There is an angle that has been proposed at this much angle is a good angle. So you go with that much angle. There has to be a padding or a cushioned surface on the top, and then there has to be a heel shock absorber or a padding, because heel is the one which takes load on the ground. So we need a shock absorption at that level. So ground reaction force has to be minimized when the heel touches the ground. So there has to be a padding on the behind portion. If we do all those things, we can solve a lot of issues like plantar fasciitis, pain, discomfort, corn callus ulcers also, and any discomfort coming around the midfoot area. So this is the basic design that is being suggested based on root theory. We discussed a little about the off-the-shelf orthotic and custom orthotic, different types of it. The purpose of using insole and orthotics for people with brain injuries or neurological deficit and all those things is not only to do correction, but to give a lot of release to the muscle. So if you have seen a lot of spastic kid or CP kids and all, their gait is so altered and they are sometimes walking more on the forefoot because their proprioception is weak. They don't have the whole thing under contact. So when they don't have any contact, the muscle is always taut and there's a lot of tension which is causing an increase in spasticity. So once you put an insole or a AFO or a orthotist, what happens is when they feel the touch from something under their feet, they will start relaxing the muscle and the tone goes down. So one of the effect of orthotics are in that area also. Then obviously for alignment correction and avoiding all other things, we are doing it. So even in case of burn patient and all, it can help in reducing the contractures around the area if it is done early. If it is a set contracture, the chances are lesser. For CP and developing issues, if it is done at an early age, or again there is a much better way. So I have a lot of CP, lot of polio clients also who are using insole, and their parents have told that it is quite better for them to manage them around, to take them out or walk and all, because they like to stand and walk a little more than before. So that you can keep in mind when you are thinking about what to do with kids as such. Again, when we are making the prescription orthotics also, there are two things that we keep in mind. One thing is the functionality and one thing is the accommodative. So when we are talking to a patient and asking them to wear an insole, they have a lot of questions because it's an extra cost for them. So you can, when you are talking to a young population who is active and mobile, not having much of a pain and discomfort, you can tell them that you are giving the insole and orthotics to improve their functionality so that they can do their day-to-day activity pain-free and do more than what they are doing right now, so that they can maintain the fitness and improve their performance. When we are talking to somebody with a permanent deformities like geriatrics or people with contractures, CP, neurological cases and all those things, you tell them that you're using it to compensate for whatever they have lost. Say for somebody who is having a leg length discrepancy, it's a compensatory and accommodative orthotics, or trying to target to improve the function. Certain time you tell them that I'm not trying to correct your flat foot. After 18 years of age, anyways, your insole, wearing the insole will not change your alignment. So you are using the insoles just to accommodate the deformity that they have, so that they can have some flexibility and ease in walking. In terms of diabetic population, again, you tell them that you have a normal arch, but I'm giving you insole to offload the tissue stress that you have. And in that cases, you might need to do temperature check of the foot. You can tell them that your temperature is higher in this zone and lower in this zone. I need to give you something which help in reducing the stress, because while you're walking, there's a lot of stress coming over here. If I don't do anything right now, you can develop a corn or a callus or an ulcer, which is non-healing and would take you on a downward curve. So it's better to be safe than sorry. When we are talking about various methods and techniques that are used to make insole, the very initial stages and still in use is the casting method. So what you do is you put a foot into a subtalar neutral position in a non-weight bearing process, and you make a cast around it. Remove the cast, take the scan of the area. So right now you have a negative cast, you take it and you turn it into a positive cast on a software, and then to construct the insole around it. Secondary method of casting was a foam casting. So what you do is you make a person sit in a comfortable chair in 90-90 degree of hip and knee flexion. You put a board of foam casting in front of them. You put the foot into a subtalar neutral position. You keep on palpating it and seeing the movement, and ask them to try and stand putting equal weight on both the side. Then you get the full impression. And again, that is processed in a machine or something, or you can make a cast out of it. Again, some POP is put on foam, and then the cast is taken, and then the insole is made accordingly. So these are more of a negative casting technique. Now in advanced clinic and all, because these are tedious also, and it takes a lot of time and make the clinic dirty to do all this thing. You have to wait a long time to the cast to dry up and all. So people use foot pressure plate or 3D scanner. So they are attached to a software which will help you in determining the length of the foot, width of the foot, type of walking pattern, pressure points and everything. So those data are collected in terms of plates and 3D scanner. The 3D scanner has a moving infrared plumb lines and all. So it takes the 3D scan in all the dimension and all the way you're standing. And then your input as a physician who has checked the foot from the history to the alignment to each and every movement. Once you check everything, you know what is happening, and then you give your input to the software, and the software then start making the insole. Now, once the data is being entered into the software, it can be made uh, through a printing method. So one is called as CNC CAD/CAM software. So the computer, there are designer, orthotist or a physiotherapist or machine specific designer who will design the insole, send the data to the CAD/CAM. The CAD/CAM will be having like a foam block kind of a thing. You can make two insoles together. So there is a cutter which will come and it will cut the whole block of foam in a form of insole, whatever is your instruction. Once that raw material, the foam material is taken out, then you choose the top cover, paste the top cover on it, do a grinding and this thing, and then you can give the insole to the patient. So again, in CAD/CAM software, there can be two kind of insole. One is EVA and one is polypropylene. So EVA is the kind of rubber. Then different density of EVA can be used as per the body weight. The density has to be maintained. If it is too soft, the insole will collapse. So you take a high grade, good quality EVA rubber, and then you put a top cover. You can make a full length total contact orthotic or a half length. Okay, so that kind of an insole can be made through that. In polypropylene, it is like the material is polypropylene, and then there is a vacuum technique through which these insoles are created. Then the latest of all is the 3D printed insole. So the 3D printers are of very high quality and expensive. So in India, that kind of a thing is not there. A low quality product is available in market, but the kind of finishing and quality that is required in making those insoles are still far off in India. That is something that these days most of the people are working on. So 3D printed insole is the next gen thing. The advantage is durability. You can have a lot of precise designing into that, and then what you can do is you can use in various varieties of sports. So, and you can change the density of the material that you're using at arch and heel and this thing much easily. If needed, usually the 3D printed insole are worn directly without any top cover. If needed, you can put a top cover, same as EVA and polypropylene. Usually the EVA thing is used. Then it comes to thermoplastic based custom insole. So this is something that we use in our clinic also. It comes with a podoscope in which when you stand, you can scan the bottom of the foot. You can check what is the alignment. This helps us to take picture from of the feet from behind, and you can show the alignment of the calcaneum through a plumb line from behind and tell them what to do, how to do, what is the alignment issue. Then if the person is convinced, then you choose the right variety of insole, because there are various of it. It comes in a plate strength of 1 to 3. Depending on the lifestyle activity, you choose the person weight and choose the insole. There is a heater attached to this machine. You put the insole inside the heater, which will make the plastic sole warm, malleable, and soft. And then there is a patented black pillow on top of it. You put the insole, then you put the patient feet on it, and in 1 minute or so the insole is ready. So total 3 to 5 minutes the insoles can be made on this and instantly can be given. When we are using a CAD/CAM software or anything, the insole takes about 2 to 3 days for delivery or more. If say you are sitting in Bombay and the CNC supplier is sitting in Bangalore, it will take that much time for them to make and then send, and it depends upon the volume and all those things. But here you can make 100% custom insole instantly and give it to the patient. Now, limitation to this is you cannot do any micromanagement in this. There is very limited thing that you can do if you want to have a cut and hold for a diabetic patient and all. It is not possible. So there are lot of small limitation that are there with them. But by far, if you see the quickest delivery and all those things, this is like something which is very good. In cases of active population without much deformity and a mid-weight, like not too obese kind of a patient, this can work. If there is a heavy weight patient, then sometimes this fails or it cracks, or it is after 6 to 8 months, it might not be useful for them. So they have to replace it to the new one. So these are like various custom insoles that are available, and I don't think we need to take a break again, so I move on to the prefabricated one. Any doubt in any of these this thing? Any type of insole, or any doubt about the techniques, what it is or what it is called? Has anybody used any type of insoles like these before? Yeah, Supradeep. Yes, sir.
Yes, ma'am. Could you hear me?
Yes, sir. Yes, sir.
Yes, ma'am. Actually, how about the silicone insoles, how they work. Actually, I used before, but
Yeah.
when I walk with that, it is comfortable. But when I run with that, jumping activities or running or jogging activities, it is like painful. It
Yes, sir.
doesn't work. Like,
Yes, sir. So that's the feedback from all the patients. So if as a physiotherapist we have prescribed, just think sometimes the patient don't come back and tell you that you have not done the right thing. So till date, a lot of orthopedic doctors or I got a patient 3 days back also severe problem, diabetic patient, full red foot, and skin condition also having pain, and the doctor said buy something soft. So he has been running around 2, 3, 4 eminent orthopedic, and then his problem was not solved. So the patient asked me why the doctor don't tell the right thing to do. So the thing is that still in our textbooks and all the same things are being taught to us, that this is how you should do, just wear a soft footwear and it goes. But now I hope after the whole day you have understood the importance of a stable uh, base for a stronger body to build on it. If the base of support is not good, you will not get any advantages in that. And another thing is that when we are talking about silicone insoles and all, it is not working on your alignment, it is only working on the cushioning. So if you expect anything beyond it, it's not going to provide you. It can only give you shock absorption, that too only when they are new for 1 month, 2 months. Even the silicone thing that is available in India is 200-300 rupees stuff, which is not good. The one I showed you is something which is imported and would last you for about an year, but still it's not gonna take care of your flattening of the arches and all those things. Any other question or doubt?
and even orthopedic expert, they are making like there may be certain materials and medial arch support. Even those things are not working that
No.
good. Like
So if it is not taking care of your three-dimensional correction, then again it will not work. If you just put an arch support, your foot was tilting here, you put an arch support, it will tilt on the other side. But if you don't cup the heel and everything, say if they take like a flat sole of the shoes, and what they do is they put an arch over here, it is not taking care of the calcaneum, it is not taking care of the lateral support and all those things. So all three arches are not getting addressed. Not the transfer, not the lateral arch, not the calcaneum is addressed. And we know the culprit is the calcaneum. Talocrural joint is something, subtalar joint is something which is causing you the trouble. So if they are not addressed, then only the medial arch raising will not help. So it has to be a deep cupping insole or orthotic that can help.
and then the last question, like I'm asking too many questions. Don't mind.
No, sir, no, sir. We are here only to discuss. Most of the knowledge that I'm giving is already there for you. So this is where I can share something. Yeah, tell me.
Like overpronated persons, they're suggesting like chiropractor walking with lateral border of the foot that may correct the alignments of the foot problem and all these things. Is that beneficial for them? Walking with the lateral border of the foot, walking on the lateral
No,
border of
sir. No, sir. So, very first thing, I'm nothing against anything, but I cannot call myself as 100% podiatrist because I have not gone through 4 years of school, college, and training. Similarly, most of the people who are adding chiropractor as in faculty, they are using half of knowledge of everything. So the traditional chiropractor and in any other country, if you go, people don't talk beyond their speciality, and exercises and all they hardly suggest you. What the chiropractor does, and typically what is the difference between a physiotherapist and a chiropractor is, it's not important to pop the joints. It's more important is let the joint be in that position for a longer duration. So when we are talking about the foot and all, for releasing it, it is okay to do a little manipulation, mobilization technique, whether it is osteopathic or chiropractic technique. But it's gonna pop back into a wrong position when you start walking. So the joints which are used on a regular basis have to be strengthened beyond the popping and all, and it has to be controlled in a better environment. Say if I have a shoulder issue and my desk height or my kitchen platform is not ergonomically designed for my height, weight, and the structure that I have, then what will happen? If I go to a chiropractor, they will pop, I will feel good, my spine is straightened up. But then again, every day I am doing the movement in the wrong direction, so it will come back again. So that is a temporary fix in a way. The more permanent fix, we have to find out what is the root cause of the problem. So locking popping is okay, but looks fancy, but to be honest, it is not gonna work for a very long duration for
Even
alignment.
ma'am,
For functional pains, like I was driving a long distance, 400-500 kilometers on road. I was driving, I was going all day long, and I was confined to the sitting position in the car, squeezed down with other members and all. And now I'm having a back pain. So if I go to a chiro, it will help me instantly. So what you are going for and what is the reason, it depends on that. The results of chiropractic techniques are much higher in those kind of cases. But since my childhood, I have never done anything for my alignment, and in my 40s, I'm saying that I feel my body is not balanced, do something. So he can just do little bit of it. It cannot permanently cure. Any more question? Should we move ahead? Had I answered you, sir? Should we move ahead? So now we come to the part where at least I can show you the prefabricated insole, which is not dependent on the machines and all. So that is the only thing that I can do today. Maybe in future, if we get an opportunity to meet in person, I would be more than happy to show you the physical evaluation part and how touching a joint will tell you all the things. It is more about how open your ears are. Even the walking of a flat-footed person, you can understand what is happening, which muscles and which joints are involved at this point. So alignment, looking at alignment, touching and feeling of the joints and all, it's something that is more interesting and helps you to do the right clinical decision making in these cases. Um, so if we are talking about Exim. So this is one brand that I use on a regular basis along with other thermoplastic company. So this come with a design of a deep heel cushion, 4 degree of arch profile. Okay, then a soft upper cover. They come in two different density, medium and hard, depending on the body weight. So if a person body weight is under 80 kg and having all kind of foot problem, you will use a medium density, and for geriatrics also you will use medium density. For lightweighted people, definitely you will use medium density. But a lightweight person with a excessive running, jogging and activity, you will use a hard density. So even if it is under 80 kg but the person is very active, you will use a little harder insole. If you are trying to target the alignment, then you will do on the harder insole. If you are trying to concentrate on the pain and symptoms and you're accommodating, and you want to reduce the pain complaints like plantar fasciitis and heel spur and all those things, then you will go for a medium density irrespective of weight. But the weight criteria is 80 below, go for medium, 80 above, go for hard density. Um, these comes with an adjustable cutting line. So say they come from extra small, small, medium, large, extra large. When you're taking a small insole, it is or a medium that is most commonly used. It is from UK 6 to 8 sizes. So in US 7 to 9 size. So you can cut as per the foot. You can cut the insole a bit and use them. So for 2 or 3 sizes, one insole is used, and in half sizes also. So per ring is a half size reduction in the length. What you do is you take out a insole from the shoes, you put it behind these insole, align them from behind to front, and see whatever is extra. If it is the lower insole is bigger, you will go for the other size of insole, a size bigger. If the insole, the shoe insole is lesser, then you put the insole like this, congruent from behind, and cut the front portion so that it can go and fit inside. Uh, Another design feature what they have is they have a first ray K layer, like we have discussed in Dannenberg, that you need a cushioning and a shock absorption under the first ray. So there is a hole and a gap over here with a poron material under this EVA plug which is there, which help in shock absorption. And in case of rigidus, you can remove this whole plug and let the foot fall down. Okay, it comes with an attachment. If it is worn out due to usage and all, you can replace it after some time. This is basically called, the arch is basically a heat moldable arch. So this is again custom molded prefabricated insole. So you can customize it, though it is prefabricated, you can customize it. The other ones like these, they don't have that capability. You cannot customize it after that, though they are insole, but these are custom molded. So if you take like a heater over here, say if somebody is wearing it and they find the arch is not coming at the right place, and the coming at the right place is between this, because this insole is for 2-3 sizes. So when they stand, maybe the arch is not congruent. So they say, I'm feeling it more over here, but not here. So if that kind of a complaint is there, you heat the insole, and there is a method that we'll cover later on to make the insole congruent to their feet. So it hugs them more perfectly and place the foot at comfort. Then behind, as we talk about the shock absorption part, so again there is a EVA shock absorber with a hole inside kind of a thing. If you see, the whole insole is very hard and rigid, but over here it will be softer to feel. But overall, these are rigid, non-flexible insole. They are not like silicone that you can compress. Even say if you see the medial arch and you put maximum pressure, if you want also, you cannot compress the arch. Otherwise, in silicone and normal this thing, it flatten out. This will never flatten out. So you first select the right insole as per the patient. So you put the patient feet on it. You can check it from the side that whether the great toe is out or not. So your first tray should be off the arch thing, because the arch is something which is rigid and will not allow. So same problem that happens with people who wear too bigger shoes. Say somebody says ki in kids, make them wear one size, two size, because they grow very fast. But what happens is even the shoe, they are having rigidity and inflexibility in this area, only flexible in the front. Now imagine your first tray, which has to be under or over a flexible area, is sitting over here. Now, while you're walking, your foot will not be allowed to flex at this thing, and that dysfunction will give you problem till above. So you need to make sure that the person feet is off, the first ray is off over here and coming on this padded surface for the shock absorption. So bigger part of foot. So that's how you choose the right size. Weight and variety you have to choose as per the weight, your clinical diagnosis about the flexibility, rigidity, the patient balance, and all those things you choose, whether for a hard density and this thing. Some companies have low, medium, high, 3 densities which are available. For the usability, the low density is very near to these kind of insoles. So those are easily available in the market. So people use medium and hard more, low is hardly used. So for the inventory purpose, some don't even keep it. Now, first step is to choose the right insole as per the size, variety, and this thing. Then you cut and trim it as per the patient requirement. remove the inner sole of the shoes, then you insert the insole and make them walk. While walking, you see the changes in the gait that is happening. Before you cut and trim, make sure that they are buying it. So that is another important factor. Otherwise, take a smaller sole and try it, and then once they are convinced, then only you cut and trim the insole. Now, once it is done, you see the deviation in the gait and all. And if you see that still the patient is overpronating and it can tolerate the arch, the hardness of the arch is not bothering them, they are actually feeling better after putting the insole, then what you do is you can start doing modifications. So as we talk about, this is custom molded free orthotic. So we have attachments coming with them, and as per our diagnosis and the goal of treatment, we will use what attachment to add to this. The insole can be of full contact, the full length insole. It could be 3/4 or it could be a slim fit. The slim fits are basically without any attachments, specifically in this company. For the purpose, they are there for stilettos or a little heels or pump shoes kind of a thing where you can just insert and walk around. Narrow fitting shoes, you can use that. The condition that you can use any insole in are pes planus, plantar fasciitis, heel spur, Achilles tendinitis, shin splint, bunion, metatarsalgia, mortis neuroma, posterior tib tendinitis, overpronation, underpronation, claw toes, hammer toes, corn callus ulcers, tapetic wound, arthritis, and all those conditions, you can use the insoles. So whenever these kind of a condition happens, you remember to do the insole thing. As I told you, you have to take out the insole and make that thing go. Now we have already discussed the importance of a good fitting shoes, proper size, length, width, everything has to be taken. Uh, Another way of checking a person whether they are wearing a wrong shoes or right shoes, take out these kind of insole, make them stand on it and see the length, okay, how they are standing on it. If there is a lot of space in the front over here, then it means they are, like, if there is 2 finger or more space over here, then it means that they are wearing too big a shoes. But then you will see that the width is well compared. So what happens in India, that we don't get narrow, medium, wide, 4 different fitting shoes, and we end up wearing a medium fitting shoes which is for general population, and we get the depth only by getting the shoe in a bigger size. Now when that is happening, just see whether the shoe is such big that the first ray can come in the midfoot area where the shoes are rigid. If that is happening, ask them to try and acquire a sport shoes or a roomy shoes in certain brands. So there are few brands which now import wide fitting shoes, and shoes like Hush Puppies and all with a removable sole, they have a broader toe box. So ask them, though the narrower shoes look good on them, but clinically it is compensating their functionality to go for a better fitting shoes as such. Then comes, so you have chosen the ideal shoes, ideal insole, and next is what you need to do for the home management. So there are insole with the same principle made on EVA, and they help in managing the alignment of the patient when even they are not wearing the shoes. So that can also be suggested for them. This is some for us. This is the top selling product between the female and middle-aged women, because of the fact that it's supposed to cushion, and even while they're standing and cooking around, it helps a lot. Now comes the wedging part. So there are some rear foot wedging, there are some forefoot wedging. In the rear foot wedging, for this particular company, there are 3 kind of wedge. One is a 2-degree rear foot, one is a 4-degree rear foot, and a heel raise that comes with that. Now, when we are talking about the varices and support like that, so if the insole is this and person is standing and still there is a pronation that is happening, you take a insole like this with a sticker, you remove the sticker, you put the insole underneath like that, and this is raised. this side it is flattened. So it will help in, and so we have inbuilt 4 degree. Now 4 degree more is added. So technically it will tilt the insole in a way that the arch is raised by 4 degree more. If you still feel that it is not sufficient, you can add another 2 degree underneath. So you can add at least that much to give you maximum correction at this area. Then if you have like a Achilles tendonitis and all those issue, comes the heel raise. So heel raise, both the ends are similar, only the behind portion, the wedge is higher. So you add it underneath for any kind of heel related issue where you want to offload the pressure on the heel. And if there is leg length, you can use both the wedge on same side, though they come as right and left, but because the edge is similar, you can use it on both the side together. So 10 mm to 12 mm you can always do. They come in 5 mm kind of a thing. It's not too much to raise 5 mm, but raising 5 mm can reduce Achilles tendonitis instantly. When you use two of them, you can do it for the leg length discrepancy and all. If the correction is too much, then you don't want to compensate the heel cupping of the shoes also. So you ask a orthotist to, as per your diagnosis, to put a sole lift. Don't go for a heel lift, go for a sole lift. So if it is like 2 centimeter, 3 centimeter kind of a case, then go for a sole lift that start from here till at least midfoot area behind the first ring. So till that you raise the whole shoe. If you do only heel raise, it will increase the pressure excessively on the forefoot area. And for that, choose a shoe with a rocker bottom. That will also help you. Then if a person is a supinator, you will still need to have the arches because you want to improve the proprioception on the medial side. Due to their high instep and everything, they are not putting pressure on the medial side. So here you will give medial arch raise for proprioception improvement and weight bearing. And on the lateral side, you will use a valgus support. So it will be again the position and everything is marked over here. So behind the fifth metatarsal, it will start. It should not be under the fifth metatarsal. No correction goes beyond this line in the forefoot area from underneath. So as per the positioning of the foot, you will make a mark on the side. So make the person stand on the shoes. Yeah. So make the person stand on the insole, flex their fifth toe up. Okay, so you know that this is where the fifth toe is resting. Make a parallel line to it on the insole. Okay, and then you put that wedge just behind that parallel line. Okay. So after marking it, you just behind that you will put this. So that will help in controlling the supination part of it. The insole is now raised from the outer edge. Now comes the metatarsal area. So we want to support the metatarsal pad to offload the pressure on the great toe, any corn, callus or ulcer. Again, the idea is same. It will not cross any joint, MTP joints. It should not be just under it. So say if this is your zone of ulcer, you will go a little behind that so that this is lifted. If you come too much closer, first thing is it will start touching the ulcer. Second thing is it will start giving more pain and discomfort in the mid metatarsal area. So you will be going a little end of uh, the midfoot joints. So this is like the ideal position. Again, it's on a sticker, you can use it. If the corn callus ulcer is healed, later on you can remove it also. So you can take it off. There are some rigid support also, they come. For certain people, they have like more sensitivity to the feet and you want a cushioning kind of way. You don't want to raise the heel too much but wants to give some soft cushioning kind of a thing, then you can use these kind of poron support. So that gives an extra shock absorption. Already there is a shock absorption, but it's only the heel. If they are having Achilles tendonitis with a little discomfort, you take these kind of a thing and you can put it into the insole. That will add extra shock absorption to your insole. So these are the attachment that you can use in this particular brand. There are certain other brand also which comes with something similar kind of a thing, or sometimes it is little different, but most of the thing whenever you take, they give you training to use that particular kind of a thing. If there is a person who is a diabetic, this thing, you can use a medium density insole like that, and there is a pink foam called as Plastazote. You can make a top cover of it, grind it, cut it, and use like some commercial glues are there which we call as SR glue. You can put a Plastazote on top of it. If you want, you can put like 1 or 2 layer of foam and cut it on the ulcer area so that the ulcer is not touching the foot and it will heal much faster. Otherwise, there are custom insole that can be made by taking the cast and CAD/CAM software and other things to make those diabetic kind of a insole. Uh, we have overextended the time. I hope it is okay with you. So now quickly I wrap up, like if with your understanding you have understood what are the challenges that can come in making an insole and orthotics, and what we can do is, so as to make like a ideal foot clinic kind of a thing, what you can do is you need basic requirement. First thing is you have to train yourself and your eyes to do this gait evaluation and physical evaluation much focused and much better. Space for the patient to walk around. If you have a smaller clinic, then you can keep a treadmill so that on a lower speed they can walk on it, which seems like a natural thing. For geriatrics, I don't prefer doing evaluation on the treadmill because adjusting to the treadmill also takes some time for them to exhibit the natural gait. But in lack of space situation, you can use a treadmill. You should always have a mirror in your clinic wherever you're making the patient walk, so that they can see themselves walking and can see those minor deviation in the hip, the bowing of the leg, the landing of the foot. At least they should be able to visualize it when they are seeing themselves in the mirror. So whatever space you are keeping for gait and posture analysis, in general also you should keep a mirror in that. If you want to show the patient that they have a concallus hard skin, which is a sign of abnormal foot pressure due to malalignment, then keep like a handheld mirror also, and you can put the mirror under the feet and show them, okay, see this, yahan pe ye ho raha, wahan pe ye ho raha. So you can tell them visually what is wrong with them, and that needs to be corrected. So patient is more attentive to your diagnosis and opt for your treatment. If possible, and you know that your patient are having a good amount of diabetic population also, then there are this infrared thermometer specifically for foot, which is designed. You put them, they are contactless and contact both. I prefer the contact one so that I can know the interphalangeal temperature also. But that is not available in India, so I got it imported. But that works in assessing the temperature at each and every point. You can have a charting of it in your this thing, and you can see like you can ask the patient whether they are coming directly to your clinic or they have walked a little distance. If you're making them exercise on their foot, and after the exercises you can take the temperature back, there should not be a very high variation in the temperature that should happen within an hour or so. If they are coming out in a sunny environment, don't take the temperature immediately. Let them cool down and wait till the end of your diagnosis to do the foot temperature. Don't do it too early, because once they come walking, their temperature is anyways higher. Then you need to have a foot measurement device. So I use a Brennock scale, which gives me in US not only the length but the width also. So that helps me in telling the patient what shoes, what size is best suitable for them in terms of length and width. So that kind of a scale, if it is there in the clinic, it comes handy for you. Very specific requirement, like if you want to have like a podiatric clinic or a foot specialty clinic, non-diabetic also, because for diabetic you need to invest on ABG and like a lot of other equipments are there to check the blood pressure in the arterial blood flow also. Then you have to see the temperature, and then you do monofilament test and all those things. So those are like still little difficult to enter. What I suggest is take the MSK situation, all the musculoskeletal pain and discomfort you can treat because you're already treating it. So just add the foot insoles and modifications to that, and it becomes easier for you to expand your area of expertise. So for that, you can have like a treadmill. That's something that you must have if you're running a foot clinic, so as to you can analyze. You can put cameras around the treadmill to do video gait analysis. You can put some money into foot pressure mats. They are ranging from 3 lakhs to 5 lakh, depending on whether they are imported or local, or what kind of a software they have. Is the software attached to a CAD/CAM software? Then the cost goes higher because they are being sold by the companies who have the CAD/CAM machinery installed. Um, then you can have like a video gate analysis kind of a thing. What we use is in the range of 2 lakh rupees, so that is sufficient for you to get the basic diagnosis of it. Then there is a 3D foot scanner. Again, it depends on who you are outsourcing the insole part. If you are outsourcing it to a CNC company or a 3D printer, then you can have an arrangement where they keep their scanner and everything for free. Or if you are doing your diagnostic thing and you want to make the insole by some other method by different people, then you have to see that the software is compatible with both CNC and 3D printing, and then you can have a 3D foot scanner. So again, they are the cheaper ones are in 70,000 and all, but the good ones are in between 1.5 lakh to 2 lakh rupees. So it depends whether you want to put a pressure plate or a 3D scanner. The pressure plate is much better in terms of giving you more data about the gate and all. In 3D scanner, you are doing more of a static thing. So knowing the dynamic part of it is little difficult through 3D scanner. And then whatever system you want to do for customize insole. For these kind of prefabricated thing, you just need your eyes and ears to see and hear what the patient has to say and do, and you can use these kind of insoles. So the investment is very cheap. You can use any good company insole. I would say anything which is ranging above 3,000 to 5,000 is something that you should use for. If it is too cheap a product, it means the quality of EVA is not there. Nobody is gonna give you product at a, I'm talking about the MRP. Nobody is gonna give you products for free to sell it. So when they are importing, they will add their charges and give you. So if it is coming cheap to you, the quality will not be there. So make sure that the products are good so that they can last you for 2 years. I have patients using it for 3.5 years also, though we say use it only for 2 years, because then the EVA is not as shock absorbing as it should be. So even the good quality will lose their, that's why you need to ask your patient even to change their shoes also. At 500 miles to 750 miles is the criteria. So in year wise, connecting with the steps they take, we say 1.5 year to 2 years. If they see any worn out sign, they should not restitch. I don't know why in India people keep on stitching the shoes and wearing it, because it lose all its purpose. Once it is broken, it is broken. It has to be replaced. So that would be on the minimum side. If you want to fancy this thing, the thermo moldable insole equipments are basically 7.5 lakh, 8 lakh kind of a thing. So that is something which is a starter kind of a thing. As a company, because I am very passionate about foot and everything, so we have a lot of franchisee clinic, we have a lot of associates, where we handhold, we train them, we help them with certain cases where they are confused about this thing. We have extensive training program for them so that they know how to assess the patient, how to treat them fine, and then we help them choose the right kind of a vendor that can help, the right kind of a machine which can be installed, help them with the evaluation process also. So that is something that we do as a company to help others set up this thing. For 10 years I'm doing this. Many a time people say why I want to teach this unique thing to everybody, won't it create a competition? So yeah, it will create a little of competition, but try to understand India is now standing at a population of 130 crore people, which means 260 crore feet. And if there are problems happening to them, I cannot be everywhere and I cannot treat everyone. But the kind of knowledge if I share with others, it can benefit crores of population. So I am not shying off letting you know all the trade secret. If you want any help, I'm there to help you to set up your clinic, and I want you all to make good money out of it, because these products carry a margin. You're not giving anything wrong to the patient. You're not harming their health in any way. You're only making them better. So there is no doubt that you can make money out of it. You can have a specialized once a week kind of foot focused clinic, but on your day-to-day this thing, always do full gait analysis and foot analysis for each and every patient. Don't examine your patient with the shoes on. The simple thing is that always remove the shoes, even if you're doing the knee examination or shoulder examination, and see them walking for 2-3 minutes at least, when they are not even having the attention. Or if you want, you can do a proper full gait analysis and foot evaluation depending on the time. In case of knee and hip, now I think you are very much keen on doing foot examination, but check for other joint also, for even shoulder pain and everything. If you have a leg length issue, even the shoulder will give you a problem. So that correlation we have discussed earlier. Try to examine. The more you see, the more problem you will see. A typical thing that I have heard more when we do all the practical trainings and all is, people start noticing the shoes now. So they keep on sending me pictures of, see ma'am, I saw this on airport, this person is wearing this leg is going like that. So that kind of attention which might not be there before will start coming to you. And if you explore it further, you will definitely see a lot of improvement on the professional aspect also. So that's it from my side. I'm very thankful for all of you. We extended the time also, so please accept my apologies for that. If still there is any doubt, we can discuss quickly. If anything else out of a sort of, you can let us know what is need to be done. Any doubt that we need to discuss, anything that you want to ask? I will stop sharing now. Yeah.
Please ask the questions. Please unmute and ask questions.
This is Devi Chakraborty. I want to ask one question.
Yes, sir.
Yes, ma'am. Like what I wanted to know, what is the exact relation between the temporomandibular joint dysfunction and the food problem or food
So if your foot are unbalanced, your left and right side of the body is not balanced. So it can affect your other joints also. That's the thing. Not every case will be like that, but certain time it do happen.
yeah, seen one patient that is having temporomandibular joint dysfunction as well as food problem. That's I asked.
So
Thank you, ma'am. Yeah.
I'm talking about, I was giving that as an example in the domino effect. I'm not saying that every case of TMJ will be associated with foot pain, but there can be a correlation. If you don't keep your eyes open, you will miss.
Okay, ma'am.
Thank you. Any other doubt or questions from your side?
Hello. Yes,
Yeah.
ma'am. Yeah, ma'am. Actually, a few days ago, I met with a patient. He was facing some kind of foot pain. And when I asked about the intensity of the pain, he was like that, "Okay, I'm acquainted to this pain now. I cannot say that it is going more than 5 or under 10 or something like that, but he was acquainted with the pain." And when I assessed him, he was in the overpronation thing. And when I opted to assess his posture as well, what I found that he was having the angle of the head and the shoulder angle. He was having more of the forward head tilted was there, and some kind of issues were there with the cervical and the upper thoracic region as well. There is there was some kind of changes over there. So when I gave him the when I aligned his foot and gave him the insoles, And would you recommend me to go for a posture analysis as well? And if it is yes, then after how many days should I go for that?
So these kind of posture analysis, if you do, you will not see any instant effect. It will
Okay.
be only subjective results that you will see. Now forward neck has happened, so it will not go back on its own. Just by putting an insole, the forward neck posture is not gonna get corrected. But now you have set him in the right direction. So if you correct the foot and start doing your cervical rehabilitation as usual, doing the strengthening of other muscles around the neck and shoulder, upper trapezius and all, then you will see the improvement happening. So you will start doing the back strengthening exercises and this thing, and then you will see. If it is a taut muscle, again, you can use the muscle release technique around the neck and upper back so that the neck can be seen going back into the position instantly. But those instant results should get into permanent. So for getting them permanent, you need to correct the alignment, the ergonomics, and everything, because apart from that there would be some ergonomic issue also. So again, it helps you to make a right decision making by asking a lot of question about what came first. So is the cervical pain behind more years before this thing, or flat foot is a major complaint for him for a long time? So it depends on that. So again, both has to be focused. It cannot be only the foot that can solve all the problems.
Okay, perfect, ma'am. Thank you.
Anybody else? Dr. Saurabh, should we end it, or anything else that you have to announce? Dr. Saurabh?
Yeah, anyone else has any kind of doubt? Ma'am is ready to take your questions. I think, ma'am, I think they need to go through the subject and then probably they might ask you.
Thank you so much, Dr. Saurabh.
It was a brilliant introduction. No doubt about it. In between for half an hour, I was not there. I had some questions. So otherwise, yeah, good research, that no doubt. And I think that let us let them go through the manuals or whatever you give. So if there anything is that man is there to solve. And one more thing, that there is a feedback link. It will be given in the group at last. So once you fill up the feedback link and submit it, your certificate will be generated and it will be sent to the personal mailbox. So please do that. Unless you do the feedback link, it won't be getting so soon. So please go through the link. It's just 2 minutes work, and then your certificate will be coming to your mailbox anytime within 3 hours. So it was a brilliant interaction and amazing delivery of content. Of course, the course content was very much, and then we were delayed for about 30 to 40 minutes, but still okay. And then we are hoping that Corona pandemic comes down, and then we'll be catching for the physical event too, because it is many of things which has to be practiced and observed on the patient too. So see you, sir. I think he is a little busy in some other webinar. So okay, then thank you so much, ma'am, for accepting the invitation and done your job so brilliantly.
Please give my regards to the whole team. Everyone has come up with the whole thing and organized on the Dashera, taking out time from everything. So please.
Yeah, we are working 365 days.
Give my personal regards to everyone.
And thank you so much. And one more thing, that dear participant, if you can send some 30 to 40 seconds of like a selfie video kind of thing about the madam and about the content, whatever you got to know today, and about the MRA. 30 to 40 seconds of selfie video also will be too good. You can just take a selfie video of yourself from your mobile and then just post on the group. Our technical team will take it to the social media and then we'll select it. I think Dr. Diwakar is joined.
Yeah, in the WhatsApp group only.
Yeah, in WhatsApp group only. That's easy.
Okay, madam, with your permission, can we conclude?
Yes, sir. Thank you so much.
Thank you so much. Thank you so much.
Everybody.
Thanks, everybody.
Thanks, madam. Once again, happy Dasara.
Thanks, everyone.
Good day. Happy Dashera to all.
Thanks, madam.
Okay.
Thank you.